Good evening. Welcome everyone to tonight's educational forum of alcohol and substance abuse. Are we on it? We all recognize that substance abuse is a national problem and not simply a problem of Southbridge alone. Our town council feels this is an important issue that needs to be addressed. As chairman of the Protection of Persons and Property Subcommittee, I feel that we can make a difference in our community if we all work together. Councilor Sean Moriarty will introduce our first guest, Gloucester Police Chief Leonard Campanello, and then moderate this portion of our program, which will run a total of 30 minutes. Thanks for being here. Sean?
Thank you. It was earlier this summer, about 4 or 5 months ago, that I saw a post online from former councilor and current school committee member Amelia Peliquin from an Oakland. She was sharing a post from an Oakland, California media outlet about a proactive approach to the opiate epidemic that has swept this country. And this is a successful proactive approach that is based about 90 miles away from us out in Gloucester. I read the article and Googled the program, did some research on that, and shared that KTVU article through my own town council Facebook page and with my own thoughts. And each of the responses I saw on that page through messages, through phone calls and so forth were very positive and interested in seeing how we could kind of take what was going on in Gloucester, that initiative out there, and kind of conform that to something that would work here in Southbridge. Within the first 90 days of Chief Leonard Campanello rolling out the Gloucester initiative, nearly 150 people took advantage of that opportunity for help. The program has received local, regional, and national attention coast to coast, and in some of the most well-known and reputable news agencies and publications. A couple of months ago, when Councilor Vecchia first proposed tonight's forum, bringing in the folks behind the Gloucester initiative was one of my big desires or wants for this. The number of deadly overdoses here in Massachusetts alone has grown exponentially over the last several years, including more than 1,200 last year alone. Chief Leonard Campanello has been Gloucester's police chief since 2012, after previously serving 23 years in the Saugus Police Department, including several years as an undercover plainclothes member of the Narcotics Investigation Unit, so certainly a guy who has seen exactly what this is like on the streets, but also from his spot now as a police chief. So at this point, I guess we would like to welcome Chief Campanello forward.
Could you sit at the table? Right.
Yeah. Want to move?
The two of you, why don't you go sit? You want to sit with him? Is that all right with you?
You told me to sit there.
No, I know, but why you weren't on?
My new best friend Al told me to sit there. So I'm not sure. Thank you, Town Council and the town of Southbridge, and of course Chief Woodson for having us down here to talk a little bit about our program. It's something that we never expected to be so far-reaching. We did it for our own citizens and our own community to combat what we saw as a problem that the police could become involved in, law enforcement could become involved in. To my right is John Rosenthal, who is the co-founder of PARI, the Police Assisted Addiction Recovery Initiative. That is the nationwide nonprofit that's been spurned out of the Gloucester Initiative, and he'll explain a little bit of that to you and how it can assist here in Southbridge as well. The Gloucester program was designed as a result of a community forum that we had back in May, and an answer to the community's call for law enforcement to do more than just be an enforcer of possessory laws, the laws of possession of illegal substances, to be more of a facilitator for an addict who we knew was not a criminal in and of itself, in and of themselves, but a person who was in need of treatment. We've known for a long time that addiction is a disease. Addiction in and of itself is not a crime. And the simple fact that someone possesses an illegal substance, a statutorily illegal substance, in this particular case did not warrant neglect on the part of helping them. So we decided to take a proactive approach in Gloucester on a three-tiered level, which was to try to start a dialogue with the legislation, both at a local, state, and federal level, about earmarking some funding for addiction recovery. The addiction recovery funding that we identified that was more or less discretionary in the police department was the asset forfeiture money, which is both at a state and federal level. As it stands now, asset forfeiture money is money that's adjudicated from criminal cases against drug dealers. When drug dealers are arrested, their assets are seized, whether it be cash or property. When the case is adjudicated, the municipalities who have participated in the investigation are awarded a portion of that money, depending on whether it's a state or federal case. That money is used for a wide variety of things. We felt that it could be, at least a percentage of that money could be mandated to assist in addiction recovery. So that was one tier. The second tier was our Narcan program. At the time we started this initiative, Narcan was deregulated. It is deregulated in Massachusetts from a prescription to an over-the-pharmaceutical counter, over-the-pharmacy counter, sort of like your Sudafed that has that ingredient in it that you just can't pick it up off the shelf. You have to get it from the pharmacist. But it was selling, if you had insurance, it was selling for $3 a dose. If you didn't have it in Gloucester, you were paying $140 a dose. We felt that was almost criminal in and of itself to deny a life-saving drug from someone who needed it. We caught a little bit of backlash from people who said, and I'm trying to speak quickly here, I know that you guys are under time constraints and I want John to fill you in on everything Pari is doing. We had a little bit of backlash on that from people who said, well, you're just giving the addict another chance to shoot up or another chance to kill themselves or another chance to have a safety net. You know, they're just going to keep doing the drug. We made a very clear distinction of no judgment, and that, I think, was a provocation in and of itself. We said that the notion, first of all, we gave it to family members and anybody who wanted it, not just the addict. So a family member did not have to wait that 4 to 6 minutes while they found their unresponsive loved one on the floor without the ability to do anything. They had the life-saving medication there. And we said that the simple notion that someone might exploit the fact that we were paying for Narcan to further their own habit did not negate our responsibility in public safety to provide a life-saving drug if we had the means to do so. We don't get the opportunity to make that judgment. We've done a lot of that in the history of law enforcement, but the reality is that we don't get to make judgment. All we're charged to do is protect and serve, and that's one way we can do it. So we decided we would use our asset forfeiture money to pay for Narcan for those who couldn't afford it. We didn't have to do that for long. CVS and Walgreens jumped on board as soon as we announced the program and said, we know your local pharmacy doesn't buy in bulk. They can't afford to sell it for any less than $140. We'll sell it to anybody for $20 a dose. So we immediately solved the problem of Narcan pricing in Gloucester. The third and probably the most provocative piece of the Angel Initiative, the Gloucester Initiative, was our Angel program, which was a statement that the Gloucester PD, if you walked into the Gloucester Police Department with or without any drugs and asked us for help, we would no longer arrest you. We would refuse to arrest that person. Instead, we would do everything that we could to facilitate treatment. Amidst the cries of there are no beds, there are no services, there is nothing to do with someone, we would see what we could do. We would also assign that person an angel, what we were calling an angel, a member of the community who was willing to volunteer their time to just simply sit with the addicted person while they were going through the process of being placed into some sort of treatment. We had no idea where that would lead, but we knew we didn't have to overcomplicate anything. Since the initiative began, as of today, 278 people have walked through the Gloucester doors and have been placed into treatment, if not immediately, within 24 hours. There are beds. There are plenty of beds, and they're everywhere. The problem is that you have to have people who are willing to make those phone calls. And the police department is open 24/7, and we have plenty of time. We're a clinician model or an emergency room model or some model that someone has to do 1,000 things after they're with you. Doesn't necessarily have that opportunity, but we never stop calling until we place a person. and there are beds. So those were the 3 tiers of our program. It started June 1st. We've since partnered with 55 facilities in 19 states. We have over $6 million in scholarship beds and treatment available across the United States if we can't find anything in Massachusetts. 39 police departments in 9 states have come on board. We have another 88 police departments that we just can't catch up with who want to be part of this. Perhaps, 2 of the most compelling things we've seen is, actually 3 of the most compelling things we've seen is the ancillary benefits from simply facilitating treatment. To arrest a person for possession of a Class A substance, which is usually heroin, we figured the cost, if you arrest them on a Tuesday afternoon at 4 o'clock, the cost to process them in, to hold them for the night, to have them appear before the judge, and to have that case adjudicated for that day was an approximate cost of $220 to the taxpayer. The cost of the police department facilitating someone into treatment, not providing that treatment, but facilitating treatment, is $55 out of the seizure fund for each of those 278 people that we've placed into treatment. That's an average cost. So it's a quarter of the cost, and it doesn't cost the taxpayer a dime. We've also seen what preliminarily and very encouragingly looks like what was originally reported as a 23% reduction. We're now seeing it as a 31% reduction in the number of ancillary crimes that are usually attributed to drug addiction, which are burglary, larceny, B&Es, shoplifting, and of course possession. We are also seeing that in Gloucester, we had 5 fatal overdoses in the first 5 months of 2015, which was one of the prompts for our response in this fashion. And while any death due to this illness is tragic, we have seen 1 death since this program began in June, and that's 5 months later. So there are a lot of compelling things that are going on while this program is running behind the scenes, and it seems to be gaining momentum everywhere, and I think that's why we're here in Southbridge. PARI, of course, was created as a result of this, and I'd like John Rosenthal to fill you in a little bit about what PARI does.
Thanks, and it's great to be here. So my name's John Rosenthal, and I am president of a company called Meredith Management, and we have a very long history in the town of Southbridge, having owned Brookside Terrace for, since 1980. And frankly, I think it was about 15 years ago or so, I sat in this very room talking to select folks about trying to do a provocative program where we could dedicate 20 units for women in recovery to reunite them with their kids. And it was quite a successful program. It helped stabilize and provide options for folks coming out of treatment. And lo and behold, 15 years later, here I'm back. And that's largely because I live in Gloucester, and the chief, after he put out a Facebook post back in, I guess probably March, April, when we first started talking about this, had 2.2 million hits on his Facebook post, and he approached me and said, uh-oh, we're going to be drinking from a fire hose. I need help. Let's set up a nonprofit. Would you consider chairing it and helping partner? And so we did. We created the Police Assisted Addiction and Recovery Initiative. It's pariusa.org on the web. And the goal is to help sustain the Gloucester Initiative, help raise funds to sustain the Gloucester Initiative, as well as help replicate it around the state and country. I mean, if you had said back then that just a few months into this, we'd have 38 departments in 9 states and 54 treatment centers in 18 states partnering with us. And I was just at a State House press conference with the governor today who launched his anti-stigma campaign against the stigma of addiction. I mean, it is taking off, and the White House is now using our language around the need to start to look at this as a combination of physical and mental health. The disease of addiction. Half of us are probably born with the gene, and others of us, end up with some kind of ailment that leads to oftentimes addiction. And we know that 80% of folks that present with heroin, with the disease of heroin addiction, start with legally prescribed painkillers that are often aggressively marketed by the pharmaceutical companies and overprescribed by docs. And then once somebody's hooked, they doctor shop, and there isn't enough monitoring that goes on around between doctors. And then when you get shut off, that pill that was prescribed or that was $80, or $50 to $80 on the street is a lot more expensive than a $10 bag of heroin. And off, and there goes the epidemic. So I am a firm believer that in order to change anything, you got to start with changing the conversation. And in short order, we have begun to change the conversation from this is, addiction and junkie and low life to this is a person suffering with the disease of addiction. We have to create a continuum of care, no different than diabetes or any other chronic illness. And when you combine, the big dirty secret is, we are woefully, lacking in mental health counseling, and the combination of, mental health and medicating, can often turn into this disease of addiction. So I'm very encouraged by the reception. Clearly, we need more communities to join forces. And we are at the point where we can offer Southbridge and other police departments our network of treatment programs. But I got to say that right here in your very community is one of the very best treatment programs that is partnering with us. They are the most dedicated, they are the most available, they're the most down-to-earth and supportive of this program and their spectrum right here in your community. You are lucky to have them here. And of course, you're lucky to have a law enforcement agency that cares and this is the basis for community policing, and you guys do that already. So now you're just adding, more compassion to those who are most vulnerable, and then, the ancillary, all the other consequences like reduction in crime as a result of treating these folks. I mean, think about all the people, we have now 278 folks that are in treatment that likely would be on the street suffering, or breaking and entering. So it's really a win-win. And you will see legislation coming down the pike probably early next year, but the governor, the Senate president, the House Speaker are all working on legislation. I think you're going to start to see way more attention, not just on the issue, but on how to solve it. And what's needed is regional centers that deal with a continuum of care, that literally treat this disease just like any other. And, it's a chronic illness, so people will relapse. But in the case of Gloucester, we just say, come back. There is no downside in trying to save folks who are suffering from this disease. And as we all know, I mean, I'm not going to embarrass anybody here, but I don't know a family that doesn't have an addict now. I do not know one single family, whether it's alcohol or opiates. And so, there but for the grace of God go we. And law enforcement has been a traditionally really conservative entity, and they have changed the conversation. And, we ask our first responders to do far more than we should, because so many of us drop the ball on participating in our democracy. But this is a really good way for law enforcement and you all to support your law enforcement and in your community help those in need. So PARI is here to help, and will help your law enforcement agency. We can provide grants, we can provide other support, but we're here to provide resources so that you don't have to reinvent the wheel if you choose to replicate all or are part of the Gloucester Initiative.
Sure. Chief Campanello, just briefly, in your experience, both as a guy who was working narcotics and working as a patrolman and other ranks up to your involvement here now, could you talk a little bit about just what the kind of stark difference that you may or may not see regarding recidivism and relapse and so forth between those who try to self-medicate, handle this without knowing where to go, versus those who actually get the help they need and get to find a bed in one of those sorts of environments?
I think you're asking a medical question there, but I'll tell you that in my experience, I have very, very rarely seen, and this is why it presents as an illness as opposed to a choice. Very, 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 very rarely have I seen in 26 years of law enforcement anyone who could withdraw and stay in remission from this disease by themselves. And I'll echo what John said is, you have the perfect combination of law enforcement and Spectrum who never takes no for an answer. Spectrum knows what they're doing. They're expanding. They're leading the charge. They've probably taken in 30% of the 278 people we've brought in, and they are always there on the other side of the line. So you are poised to do great work here. I don't think there are many people out there at all who can self-withdraw.
Okay. But from what you see with the people who are able to get into these programs, in terms of if they were not in these programs and the kind of crimes they would commit, nonviolent or violent, the comparison, I guess, is what I'm looking for, is to those who are trying to deal with it on their own or don't know where to go, those sorts of people who are trying to kick those habits or not trying to kick those habits, the crime rate there versus what you see out of these folks here that have been treated.
So I think we're very early in that. We're 5 months in, and the efficacy of the law enforcement portion of this does not rely solely on the recidivism rate. Our job is, as we saw in Gloucester, was to facilitate treatment instead of arrest, and it's up to the treatment facilities to figure out what the best treatment is for each individual. This presents no different than cancer. If you and I had the same type of cancer, you might get treated with surgery. I might get 6 months of chemo. You don't know. But I will tell you that without anything to back this up other than phone calls and reaching out, that our recidivism rate seems to be much lower than a typical program. And we think that's not anything to do with how great we're doing. We think that people who need a safe haven, who need a place to go, and are at the point where they walk into a police department, they're ready for that treatment. You cannot treat an addict who does not want help. And that's not to say that it's a choice at all. You can't treat a cancer patient that doesn't want help. You can't treat a diabetic that doesn't want help. You cannot treat an addict that doesn't want help. And that's why none of the court-ordered systems have the effectiveness that this simple plan of inviting someone in and saying, there's no judgment here. You come in, we'll try to help you. None of the court, you're not going to hold a charge over somebody's head. They're not going to do it for their own kids. They're not going to do it for their loved ones who support them. They're going to do it when they're ready. And we have to, as communities, as leaders in communities, we have to be there at that point where they are ready. Absolutely, without a doubt.
Okay, thank you. And I also want to thank both of you for really just pointing out and referencing the unfortunate stigma that is so often just saddled with people who are trying to battle addiction and are looking for help, whether it's at a facility here in town or elsewhere. Far too often they're really kind of looked at in a very unfortunate light that is beyond. I have a family member myself, a younger brother, who is battling numerous addictions over his last 10, 15 years, who you can see a very stark difference between when he's using, when he's not, and far too often I think it's exactly what you're talking about in terms of the illness piece. It's not something that they're able to do on their own. It's something that they need that sort of help with, and that help is not always easy to obtain, and I just want to thank you for that.
The labeling and stigma, is it's lazy and it's hurtful. And I got to say that, a lot of people stigmatize law enforcement too. Mm-hmm. And to see the turnaround, at a time where there have been a lot of stories about law enforcement or a few people in law enforcement not doing the right thing across the country, I mean, to watch this guy walk down, he is a rock star in the community of Gloucester because of this program and in the sense that, I mean, it's a little bit like man bites dog, you know, that also law enforcement's taking the lead and getting people into treatment. And that has made not only the governor and the president of the United States pay attention and use this language, and, you know, we're the talk of the country around this program, but the Massachusetts health plans, the pharmaceutical companies are coming to the table. I mean, there is this nexus, this critical mass that is finally happening around this disease of addiction such that it really can get solved with the continuum of care, and it's just amazing to see law enforcement at the front edge of this.
Mm-hmm. Councilor Steves?
Thank you. Thank you for coming, both of you, first of all. I guess this is primarily directed to the chief. How do you address the fact that many addicts already have a negative perception of the police due to being previously arrested, and to get them to trust you into doing this?
I think in anything that the police department does, you know, whenever, so this is a demographic of society, right? So you can take two views. You can say they're never going to trust us, so why should we try? Or you can take what we're supposed to be doing in any form of government and reaching out your hand and saying, at least we did that. Mm-hmm. And I think you can apply that to any demographic that doesn't trust the police. Mm-hmm. So we reached out that hand. We didn't know if we would have anyone. You know, I was told repeatedly, there is no one going to come to the police station who's an addict and turn in their drugs. They are not going to trust you. And I said, you know what? We can't do anything about that. All we can do is put out our hand and keep good to our word. Mm-hmm. You know, there's not a police chief in the country who is going to announce publicly that they're not going to arrest somebody who walks into their station and then turn around and arrest them. So as word spread, you know, here we are 278 people later, and, you know, lives are being saved. And I would refute the rock star comment. I think if you want to equate me to some 70s rock star who got old and fat really fast, that's fine. But I mean, I think that's an answer to your question. I think it's not the responsibility of the public to place their trust in the police. It's the responsibility of the police to gain trust from the public.
Sure. Also, I was wondering, I don't know if this is necessarily a question that you can answer, or maybe it would be directed more to one of the other panelists later. But how do you follow up with people to ensure that they don't fall back into addiction?
We don't care if they fall. That's part of the disease. How do you follow
Okay.
how do you follow up with a cancer patient when they come back to us for help and we help them again? We love our relapses. We don't love that they relapsed. We hurt for them, but we love that they come right back to us and we place them again. We love that they tried, and we love that they're trying again. And so I think you have to present the model like that. You have to say, you don't just get one bite at the apple. You don't get 2 bites. You get 70 bites. We had one of our success stories who had been into treatment 112 times over the last 10 years. Wow. 112 times in detox. And he knew that number like he knew the ages of his kids and the birth dates of his kids. And he's been clean for 70 days, and we keep our fingers crossed for him every single day. But we know it could happen tomorrow, and we want him to come back instead of staying out on the street for 6 months.
Thank you.
There's also, just as we've changed the conversation around, you know, trying to remove the stigma, we're also trying to change the conversation around what it takes in the form of a continuum of care. So it's a hard conversation to have because it is going to cost money, but it's not going to cost as much money as the failed war on drugs, I can tell you that. So, you know, from detox to inpatient to outpatient to ongoing counseling. And if we can set up regional centers around the state that actually can follow that continuum, so you know, for those that relapse, they can come back in. And it's going to be around mental health and, you know, knowing all the options. There's, you know, medication-assisted treatment really, really works with this disease. So does abstinence. You know, there's going to be all kinds of options. And not, you know, it's not one size fits all, but there's not 100 of them. There's really, a handful that work and need to be made available. And people need to know that they're not just the scourge of society. They have a disease, people care. That's a big part of the recovery process right there.
Right. Also? Any other questions or comments? Mr. Manager?
I know we only have a half an hour for each person, so I have a lot of questions, but I'm not going to ask them tonight. But I guess I would ask you one simple question. Have you documented this program in such a way as that you could send us kind of the documented program so I can look through it more thoroughly and then ask you questions directly at another time? It would be easier if we could kind of just get that as well.
Yeah, I think, the chief has reached out before. You have an extremely proactive and ready-to-go chief in Southbridge who I wouldn't want coming up and competing for my job in Gloucester, so you stay down here in Southbridge, okay? But we've talked. He's come up to Gloucester. He's seen the program. Did I give you the flash drive with everything on it? So he has all the documents, and as we go on, the Boston University School of Health, Dr. David Rosenblum is, figuring out the efficacy of the different parts of this program as we're 5 months into it. We're starting to discuss how we can improve it with continuous care coordination so that we can have part of the efficacy be, do we have people in remission for a long time as a result of this program? But yes, the chief has everything, all the forms, and also Parry has access to all the police department's model policies that have joined up. And it's a cafeteria plan. If Southbridge doesn't want to adopt the Gloucester initiative, but sees another way that it can help its own citizens, because you guys are the ones who know your own town the most, then there are model policies from all over the country that take all the parts of this demand side solution to a problem and incorporate them here.
Terrific. Thank you very much.
My pleasure.
And with that, I know that I'm sure there are other people who have questions, and there are other questions I'd love to ask as well, but I know that they've arranged this in a half-hour format, and we're pretty much up against it at this point, so I'll turn it back over to Mr. Vecchia, Councilor Vecchia.
I'd like to thank both of you for coming, and would you please mind coming up here? I'd like to shake your hand.
It's not every day you get to shake hands with rock stars.
That's right. Thank you for coming.
It's our pleasure.
Thank you very much for coming. Thank you so much.
Nice to meet you. Thanks for having us. Pleasure to meet you.
Thank you so much.
Well, I mean, asking quite a few. Thank you, gentlemen.
Okay, we're going to move on. State Rep Peter Durant was supposed to introduce the next two speakers. He's on his way, but he's not here yet, so I'll introduce the first speaker, attorney from the Attorney General's office, Bart Hollander. He's a Hadley resident, has served as regional chief for Attorney General Myra Healy's Western Massachusetts Division since his appointment in June of 2013 by Attorney General Crockley. Bart also previously served the Western Massachusetts Division as acting chief and as deputy chief. Take it away, sir.
Thank you very much. I know I'm probably not known to anybody in this room save the program manager from our office, Catherine Madden, who's doing an outstanding job on Attorney General Maura Healy's opiate task force. But should anyone feel moved to refer to me as a rock star, I will not deny that designation by the time the evening is over. In all seriousness, I am very privileged and proud to be before you this evening. I am, as you described, a trial lawyer by training, and I don't have any particular expertise in the medical profession or any expertise with respect to the disease of addiction. But from the beginning, Attorney General Maura Healy has made fighting the opiate epidemic a priority of her office. And from the outset, she established her own opiate task force within the Attorney General's office. And I've been privileged to be a member of that task force as the regional chief for the Western Massachusetts Division in Springfield. One of the first functions that I attended as a member of the Opiate Task Force for Attorney General Maura Healey was to sit in on one of the governor's listening sessions in Greenfield, at Greenfield Community College in March of this year, 2015. And that was set up to have the public come forward and say whatever they were moved to say about this disease of addiction, and specifically the scourge of opiate abuse. And that evening we heard a great deal of folks describe very tragic stories of how opiate abuse and prescription drug abuse had touched their families, had killed loved ones, and devastated their families. We heard that over and over, and it was very difficult to listen to those heart-wrenching stories. But one other thing we heard a number of times throughout those hours from these folks in the community was, thank you. Thank you for shining a spotlight on this issue. Thank you for sitting and listening and letting us know, as folks who are battling this disease and have family members who are battling this disease, thank you for letting us know that we don't have to battle it alone, that you are listening, that you are taking an approach of all hands on deck to battle this statewide and nationwide epidemic. So with that, I would say thank you to everyone assembled here, the Southbridge Council, Representative Peter Durant, whose office invited the Attorney General's office to participate this evening, all of the law enforcement personnel and the medical personnel who are here tonight to help shine the spotlight on this epidemic. And in doing so, we start to take steps towards battling it. And as A.G. Healey has made very clear to her office, this battle has to be all hands on deck. And that's what this forum is about this evening. Heroin and prescription painkillers are claiming the lives of 4 people a day in Massachusetts. Here in Worcester County, the numbers are alarming. Since 2012, there's been a 75% increase in overdose fatalities in the county. But those numbers, of course, don't tell the whole story. They don't tell the story of the family members who quit their jobs, missed their jobs to care for loved ones. They don't tell the story of the strain on our system for our police and fire departments, hospitals and treatment facilities, and our cities and towns. Yet too many people who take a prescription painkiller aren't aware of the risks, including the fact that 4 out of 5 heroin users started with prescription drugs. And it's the case that we are less than 5% of the world's population, yet we consume 80% of the world's opioids. And I'll repeat that. We are 5%, less than 5% of the world's population, yet we consume 80% of the world's opioids. These drugs are highly addictive. They can cause dependence in as little as 1 week. And all too often, as has already been mentioned this evening, people turn to heroin when they can no longer afford the prescription painkillers. And it's not just young people. The average overdose age in Massachusetts is around 40. And it's people from all walks of life. It's young athletes who have a sports injury. It's folks with back pain, shoulder surgery, dental procedures. So we have an overdose problem because we have a prescription painkiller problem. 4 citizens of the Commonwealth die every day because of heroin and opioid overdoses, and without Narcan, that number would be much, much higher. So we need to do something about that. The Attorney General's office has a particular role to play in this crisis. As Attorney General Maura Healey likes to say, we are the people's law firm, and we spend a lot of time thinking about how we can partner and bring our law enforcement agencies and other state agencies to this task, which again, Maura Healey views as an all-hands-on-deck statewide problem. We're looking at all the practices that got us here, from marketing by pharmaceutical companies to overprescribing by the medical community to dispensing practices by pharmacies and to the treatment coverage by insurance companies. Quick overview of the type of work the Attorney General's office has been up to. One of our priorities is to prevent opioid addiction through expanded preventative education for young people, parents, patients, pharmacists, and the medical community. And that means traveling across the state, attending community meetings like this one, visiting schools, working with state interscholastic athletic associations to reach our student athletes who are particularly vulnerable given the possibility of a sports injury and the likelihood of being prescribed an opioid. It also means working with the medical community. A few months ago, Governor Baker, Secretary Sutters, and the AG sat down with the leadership from the Massachusetts Medical Society, and we talked about the need for safe prescribing guidelines. The MMS quickly developed those guidelines, which are such an important start. The Massachusetts Hospital Association has done the same for emergency department opioid prescribing, but much more needs to be done. We need to educate primary care physicians about alternatives to opioids for pain management and why it matters, why it's so important. And we need to find a way to talk with the kids at home and at school. The earlier, the better. We need policy initiatives that prevent prescription drug diversion. Putting prescription medication into the black market is the problem, as well as enforcement actions for the drug trafficking. And we're going after the drug traffickers and the pill mills, those who are diverting prescription medication into the black market. And treatment providers who are engaging in fraudulent or unlawful billing practices in an attempt to profit off of this crisis. To make this happen, the Attorney General's office is working closely with Massachusetts police chiefs, district attorneys, and others who are doing some incredibly innovative outreach work in their own local communities. The Attorney General's office, we also recently filed legislation to make fentanyl trafficking a crime, and we're hoping that that is on the governor's desk later this month. Fentanyl is the most powerful opioid on the market, up to 50 times more powerful than heroin, and it's being manufactured by drug cartels and mixed with heroin on our streets. It's a major contributor to the rise in overdoses. Another critical effort is to lift barriers to treatment. In 2013, of the more than 20 million Americans who needed treatment for drug or alcohol use, only about 11% received it. This situation cannot continue. We need to increase the availability of addiction recovery services in this state and build a true continuum of care that leads to long-term recovery. That means expanding our treatment system, advocating for more treatment beds and better care coordination, and ending the stigma associated with addiction that's already been mentioned here this night and by this council, and enforcing our behavioral health parity laws. We are aware that Secretary Sutters, Commissioner Burrell, and the whole team at the Office of Health and Human Services are completely committed to that approach. And it means all treatment paths need to be on the table. We have to reform a spin-dry system that has failed to give people what they need in terms of step-down services and comprehensive support. We have to make Narcan, the overdose reversal drug, more affordable, and we are working on that, and this office has had success in that area. We negotiated a settlement from the pharmaceutical company that makes the drug and worked with leaders in the legislature to put that money into a fund so that cities and towns can afford to buy Narcan. And we have to make sure that the citizens of the Commonwealth are willing to help each other. To that end, we're working to publicize our Good Samaritan law, to encourage people to call 911 when they witness an overdose and to know that they won't be prosecuted. If we work together to make these things happen, we will be successful in our battle against this health crisis, and that means lives will be saved, families will be healed, and communities will be strengthened. And in closing, perhaps because I've been married for many years to a social psychologist, and also because I like to think I'm relatively young, it's not so long ago that I was in college and learning these terms. I'm aware of the term recency and primacy, which basically suggests that what I said at the outset when I met you about being a rock star and what I'm going to say now are most likely to be remembered by you after my presentation, and everything in the middle might get lost in the shuffle. I certainly hope that's not the case, and I encourage the council to reach out to our office and any of these legislators and law enforcement officers who are here to reach out to me personally if I can be of any assistance. As I drove out here, I thought about those families that I listened to in Greenfield Community College back in March. Devastating stories. And in my own personal life, my mother passed away less than 3 weeks ago at age 72 from a massive brain aneurysm. She was in perfectly good health, and all of her sisters told me privately we thought Glee would live longer than all of us. It was a complete shock. So I'm quite frankly thinking about my mother's death quite a bit in these last few weeks because it's so close in time, and there's a way that it can tie into what we're talking about this evening and all those stories that I listened to in Greenfield Community College, and I think the point is probably obvious to all of you here. From a societal perspective, my mother's death was blameless. She had a little, a vein in a brain that failed. Society is blameless in that death. But the families I listened to in Greenfield Community College for hours upon hours, who had personal stories, from the personal story from this counselor this evening, each and every single opioid overdose death, we cannot say that society is blameless. We have to do more, and we're trying to do more. But that point is critical. I'm grateful for the fact that this council and Representative Durant and the other law enforcement personnel gathered tonight and legislators are shining a spotlight on this issue because it is rampant in our Commonwealth, it is rampant across the nation, and as a society we have to do better, and that much is clear. So we're rolling up our sleeves at the Attorney General's office, and we're trying to do that, and we're partnering with as many folks as we can to make sure that we put a stranglehold on this health epidemic. So with those words, I thank you again for inviting me here to be a representative of Attorney General Maura Healey, and I certainly am available to the council and others if you have any questions.
Go ahead, you're moderating this portion. Okay.
Thank you, Mr. Chairman. Mr. Hollander, thank you, Mr. Chamberlain, thank you for coming this evening. First, let me say I'm sorry for your loss. Having a mother-in-law who passed quickly at the young age of 70, like your mom did, it struck me that when our loved ones pass quickly like that, it's easier on them than it is on us. And I think sometimes we'd all like to go quickly, but it makes it difficult for those who are left behind. So my condolences for you.
Thank you.
And I apologize for getting here late, just getting from Boston. So I apologize if I ask questions that maybe I've already been asked of the first panel. But you said a couple of things that I thought were very interesting, and I just wanted you to touch upon them. And that was the stigma of addiction. And how do you feel, and how does the Attorney General's office feel that we can tackle that stigma that goes along with addiction so people can get the help that they need? And also, just briefly, I know the governor's legislation has, that he's worked on with the Attorney General and with the House and Senate leaders, to say, a 3-day or 72-hour prescription for opioids in your when the doctor first prescribes opiates for acute pain management, to just make it a 72-hour prescription, and then kind of let them come back and maybe move to something a little bit easier or less addictive. If you could speak just to a couple of those things and how the Attorney General's office feels about that.
Well, I appreciate both questions. I can tell you that on the issue of breaking down the stigma of this disease, this addiction, which we all recognize it's a disease that's been spoken of already this evening. This listening session, ones like it that are going on across the Commonwealth, allowing folks who have struggled with this disease through their loved ones or for themselves to hear and see that folks with the ability to tackle this problem from many, many different angles and issues are trying to do so is a very powerful tool in breaking down the stigma of this addiction. I can tell you that Attorney General Maura Healey well understands that. I've sat with her at ROCA in Springfield. She sits with young men who have been addicted and are trying to make something of their lives. All of these support services that are available for folks. We're going into these community organizations, and we're literally reaching out our hand and saying, your Office of the Attorney General cares for you. Your state and local representatives here care for you. Tell us how we can help. How can we help you find a job? How can we remove state laws that make it so difficult for you to get a job after you've been convicted of a felony, which may have been, the impetus for that may have simply been your addiction, a disease that you could not control on your own. So breaking down the stigmatism, or the stigma, excuse me, of heroin addiction and opioid addiction is happening all across the state. Attorney General Healey is very sensitive to that issue. I know Governor Baker is sensitive to that issue. These types of community forums are doing a great deal, probably more than we realize in the couple of hours that we'll spend together. Now I'm going to sidestep as if I were a trained politician, which I'm not. I'm a trial lawyer. The second question, because I don't want to speak for my office. I was asked by AG Healey to come here and be present on behalf of the office at Representative Durant's request. I don't want to go on a record, particularly under these bright lights that are starting to make me feel like I'm a rock star after all, on the 72-hour proposal of Governor Baker. But I'm very grateful for the time that you've afforded me this evening, and if there are other questions, you might see my sidestep dance, or I'll do my best to answer them.
Are there other questions? Sure.
I do. Actually, some of the things you were saying I thought were really interesting because you seem to there seems to be an effort in the Attorney General's office to kind of tie the drug addiction to a variety of other things going on as well. And I think that to be honest with you, that we in our society need to start looking at the big picture issues because we seem to have an issue in our society that's not just addiction in terms of drugs and alcohol, but there seems to be an awful lot of things going on in our economy that are addictive in general. And you guys, I know the Attorney General's office talks about, for example, economic crimes and things like that. Is there any effort in there to tie things together to really look at how the big picture is affecting the drug crisis as a whole?
Well, I think A.G. Healey's office is very much focused on the big picture insofar as with respect to this crisis, we're coming at it at many different angles. We know that there are lots of ways to get at the problem, but this problem can very much be representative of other problems in society, such as the availability of affordable housing for our hardworking employees who have to make do with what they can earn on a daily basis. There are so many factors that could factor into why somebody goes down that path to addiction, and I think we all have to recognize that there's no one single solution to getting at that problem. And the more we see the interconnections between the opioid epidemic and other societal struggles, the better we'll be at adapting to and tackling the problem. It's going to take a lot of different approaches.
And also, you kind of hinted at this, but I was hoping I don't know if you are working with medical schools. You mentioned working with some educational issues, because it seems like a lot of medical schools tend not to teach the alternatives to drug use. Are you working with that to for example, change medical school curriculum and things like that?
I would suggest that the office is considering all options available to it. I think I was at an opiate task force meeting where some of that was touched upon, insofar as I really think physicians, who we can joke are probably a tough bunch to teach, as tough as lawyers or anyone else. I think there was a indoctrination from, I forget when this thing exploded, 15, 20, 25 years ago, an indoctrination that opioids were the end-all, be-all, and they didn't have this addictive element, and that was being taught to the physicians, and the physicians were not as attentive to or aware of that culture and the danger there. So it may be changing. I suspect that with the information that we now know, notwithstanding whatever the pharmaceutical representatives and pharmaceutical companies might be suggesting about these very powerfully addictive drugs, that everybody's eyes are open now. So I think I'd like to think physicians, first do no harm. They're going to do their best to be aware of the addictive power of these medicines.
And one related question is, do you see any evidence do you have any evidence linking direct marketing of drugs to the public to the addictions?
Direct marketing of the drugs?
Direct advertising of drugs to the public to addictions.
What's the last phrase?
To the addiction crisis.
Yes,
So I guess I'm having a tough time with the question. So direct marketing of drug companies in general? Or
you know how not too long ago it was prohibited to advertise drugs directly to the public. And over the course of, I don't remember exactly when it changed, but relatively not too long ago, it changed so that the drug companies could directly advertise drugs to the public. Has that had an impact on the actual addiction crisis?
I mean, I would be ill-equipped to venture a thought about that. It sounds like it's possible, but I haven't given any thought to that angle.
We don't have any particular evidence at that point.
I don't have any evidence that I could share with you that would suggest that one way or another. Okay. I mean, I think you raise a good question, but I'm not familiar. One thing I learned by being married to a scientist is that you have to have, repeatable studies, and you have to have scientific evidence before you confirm your hypothesis.
Right.
So I would just be, suggesting something to you in a vacuum, and I don't think that'll be helpful to you.
Okay.
Thank you. All set, Mr. Steves?
Thank you.
Okay. Mr. Sandoval?
First, thank you, Representative. Attorney Hollander, my question is kind of a little bit more dealing with education, but I want to kind of set up the question. As a young man, I saw a lot of national advertising against drugs. I remember the old Ronald Reagan, just say no, your brain on drugs, seeing them get scrambled, all that. I don't see that anymore. I see that, I know that the culture has changed among our young people, where when I was a kid, heroin and cocaine were huge and very few people did it, to where now the culture, most of our kids are trying it, which is kind of scary. I see there's $5 million put aside in the action plan that the governor's proposed for education, but I really don't see a state anti-drug program. Does one exist that I just don't see? And why are we not kind of doing more through the media in terms of television and radio and billboards and some kind of anti-drug message on the preventative side?
Yeah, I don't know the answer to why. I think it's an excellent question to raise for your legislators and your executive. But I have a personal view on this issue, which is that the best education for anybody happens at home. With your parents or your grandparents or your guardian or whoever is doing the educating. At home is where you're going to learn about making smart choices about how you live your lifestyle. So I'm a strong believer that the message we send to our children starts with the message that they're getting from the loved ones who are raising them. And if we are educating the adults about this epidemic and about how quickly a young man or woman could go down the rabbit hole of addiction with these powerful opioids, that training and that education critically must happen in the households. and that's the first line of defense.
Thank you.
Ms. Clemens?
Thank you. Thank you for being here, Mr. Hollander. As you keep saying, the epidemic, you refer to it as the epidemic, and a recent article I read said that it has quadrupled since 2000, and the deaths have risen up to 8,260 as of 2013. And New England has not been exempt from this, obviously. That's why we're here discussing it for Massachusetts and for our local community. New Hampshire being one of the hardest hit in the increases, according to the information that I've read, having 325 deaths in 2014, which is a 68% increase since 2013, with the administration of Narcan, with over 1,900 administrations of Narcan, which could have been, deaths there too if they hadn't done that. They talk about being very concerned in New Hampshire because at this point they're looking at 100,000 people that need help, and yet their system, their publicly finance system that they have, only allows about 4%, which puts them in the ranking only ahead, second to last, only ahead of Texas in terms of availability for treatment. Do we here in Massachusetts have any type of numbers that we're seeing here? Not any type of numbers that indicate where we rank in facilities and availability and care and what we are doing. Obviously, the incentives that have been put forth now by the Baker campaign and all, the Baker's office and yourselves are going to do and help us out immensely. But do you have any numbers as to where we would rank perhaps in the country or in terms of?
I don't. As you suggest, I would be surprised if those numbers aren't being studied and developed. But I would venture the guess that Attorney General Healy is not particularly concerned with where we rank vis-a-vis other states, but wants to eliminate that scourge in the Commonwealth and nationwide, because it's a societal problem that we all have to pull together, and it's going to take a great deal of work. So I don't know where we stand. I certainly wouldn't suggest we're in a position where we pat ourselves on the back and we say, job well done, because we understand that we're being hit with this epidemic just like so much of the rest of the country. And I don't know how we would stack up with New Hampshire, but I would say that every indication is the job is not done, and all hands need to be on deck, and all approaches need to be explored, and every effort needs to be made from the top to the bottom, and in the homes and in the schools, and just shining the spotlight on this epidemic is an important step.
Absolutely. I just, again, looking at access to care and that type of thing, obviously that's what we're discussing here, trying to find different avenues for people to get the help that they need. And it's wonderful that the approach that's being taken currently and that continues to be advanced upon, certainly. So thank you again.
It's my pleasure.
Thank you, Mr. Hollander. Your time is up. Thank you very much for coming.
Very good. Thank you.
Thank you.
Thank you, gentlemen.
Now, I'm going to introduce Ryan Chamberlain, Director of Western Massachusetts Governor's Office, and he will be followed by Worcester's District Attorney Joseph Early Jr.
Well, thank you very much for having me. I'll make it brief because I know we're at a time crunch. First, I think there was a lot of statistics that have already been thrown out there, so I'd like to move a little bit more into what the governor is doing. As you know, when the governor took office, this was one of his top priorities. Moving forward, he quickly created the governor's opioid working group, which the Attorney General also sits on, and did a listening tour across Massachusetts. I gave you a handout of the action plan to address the opioid epidemic in the Commonwealth update that was given out on October 13th, so it's pretty recent. As far as statistics and things like that go, I know that the State Without the Stigma campaign was announced today. All this information can also be found on www.mass.gov. There's statistics, breakdown even as far as which communities in the Commonwealth are actually hit hardest by the opioid epidemic. I'd also like to note on November 2nd, the governor signed the supplemental budget, which included $27.8 million for various opioid treatments and prevention programs within Health and Human Services and the Executive Office of Education. On October 15th, the governor filed landmark substance use legislation, which I know that the legislators have been briefed on. I would like to talk, I also handed out the breakdown of that legislation to you in the second packet. And I also, if anyone from the public would like information on that, I actually brought some extra handouts for them too. Some key provisions in the Act relative to the substance use treatment and education prevention, which we're naming STEP. It limits the prescribing practices for the first-time opioid prescriptions. It allows clinicians to treat and assess patients for 72 hours. It strengthens the prescription monitoring programs. It mandates control substance training for practitioners. It requires education training on substance misuse for coaches and parents. It amends the civil commitment statute, which is Section 35 of Chapter 123. I wish the member from the Attorney General's office could probably answer that question for you. Requires insurers to file opioid management policies and improves access to recovery high schools. And this has kind of been a big push for the Baker-Polito administration. And I know that the governor would really like to see this acted upon as soon as possible. I will be brief. I'm very happy to be here representing the governor and the lieutenant governor. This is absolutely not my area of expertise per se, but I'm happy to follow up with anybody on any questions that they would like answered. And I'm just very excited to be able to be here and engage with a community who has taken a proactive stance on the opioid epidemic. And I appreciate the time to speak today.
Thank you, Mr. Chamberlain. Are there questions from the board? Oh, we're going to let you off the hook easy.
I got off easy. Thank you very much.
Thank you.
Thank you very much. As we move on, I'm going to introduce Councilor Gus Steves, who's the chairman of the Health Education Subcommittee, and he will introduce DA Joseph Early Jr.
Hi, thank you all for coming, first of all. DA Joseph Early Jr. has worked with the law enforcement agencies in 60 cities and towns that make up the Worcester District. The biggest issue, he was elected in 2006. Previously, he was ADA in Hampton County. He spent 2 years in the Attorney General's office, and he practiced law for 17 years in the interim. So, welcome to you, Mr. Early.
Good evening. Thank you for the opportunity to be here. Proud to be part of tonight's forum. And I want to thank the Southbridge Town Council and City Manager San Angelo, as well as Councilor Vecchia and all the others who helped put this on. It couldn't be more timely. What we're finding out right now, as the District Attorney for Worcester County, we see the heartache, we see the heartbreak every day. Every day. We never thought we'd be in a situation like this. It's ravaging our region. It doesn't have any boundaries. It's a nationwide problem. It doesn't have any socioeconomic borders. It's in every community. It's killing our sons. It's killing our daughters. It's killing our friends. It's killing cousins. It's killing so many good people. And whether your family has been touched by it or not, the crisis has impacted your family one way or another. Whether it be the opiates themselves, whether it be the other crime, whether it be the breaking and enterings, whether it be the shopliftings. What's amazing so far this year is that we have 97 suspected heroin overdoses in Worcester County, 97 through today. There have been fatalities in 32 communities, including Southbridge, as you well know. I've heard it said a couple of times now, but imagine what the numbers would look like if we didn't have Narcan. I saw Narcan work. I was fortunate enough to see it work myself. I was down at Crompton Park in Worcester watching a basketball game. Before you know it, I saw 2 cruisers, 2 ambulances, 2 fire engines, and I walked over, said to the officer, I knew the police officer, I said, Pete, what's going on? He said, Joe, we got an overdose. I said, did you try Narcan? He said, watch this. It was amazing. Within a minute, he popped up. The gentleman asked where he was. The EMTs told him that he had overdosed and would he like to go to the hospital. He was lucky. He said, sure. 3 weeks ago, your police department, along with our office, issued a warning about a particularly bad batch of heroin that was in Southbridge. The warning got out there quick, but there were many things that had to be considered. One has been mentioned, the stigma. Do you want that affiliated with the town? Was it serious enough to put it out there? Two, ironically enough, when you do put it out, the heroin users themselves want to buy that heroin. They want to know where the most potent, most powerful stuff is. They're trying always to find that first high. The irony, it's not lost on anyone, but that's what we've come to. It's gotten that bad. As we know now, many people in Massachusetts, more people in Massachusetts die from opioid deaths, opioid abuse, than they do in car crashes. And as the death toll rises, in our opiates, death toll rises, we all have to be mindful of the fact that the victims aren't mere statistics on a spreadsheet, but they're human beings with families who are so often devastated by their loss. As the district attorney, I get every unattended death in the county. And it really is Worcester County. We have Bellingham as well. We lost Ethel, but it really is Worcester County. And what we know, talking to people, that the pain is just so real. And I'm seeing 19-year-olds, 21-year-olds, 23-year-olds, 25-year-olds now popping up on the overdose sheets. At a recent candlelight vigil on Overdose Awareness Day, I talked to a friend of mine I hadn't seen in years, and I asked, John, how you doing? He said, well, Joe, my son died 3 weeks ago. We're getting so many that I can't always remember the death of every person who's died an unattended death because of opioids. But it has to stop. That's why we formed the countywide opioid drug task force earlier this year. Your chief of police is on it. I know Senator Fatman's on it, as well as his wife, Register of Probate Stephanie Fatman. I know our sheriff is on it. So many good people on the task force. We have representatives from healthcare, from treatment and recovery, law enforcement and government, a lot of bright people dedicated to the fight against addiction. We need to find solutions. I heard a question that was asked not too long ago about what we have for numbers, whether or not there's universal treatment with regards to the heroin and opioids. What I do know is that we, as a collectively, as a community, we're getting smarter on it. Our community outreach team is out in the schools every day. We've been in Southbridge with many presentations, whether it be bullying, texting, and driving, drugs and alcohol, but we're getting our program even better. We recently showed the Hungry Heart movie up in Fitchburg, and I'm going to be offering it here. I've already offered it to Bay Path, but we're going to be offering it to Southbridge, which shows the devastation and impact that it had on a small town in Vermont. We recently were fortunate enough to receive the prestigious Hal Rogers Grant, almost $400,000 over the next 2 years to fight opioid abuse in Worcester County. It's going to allow us to better track overdose statistics. It's going to allow us, through the prescription drug monitoring problem, to perhaps get an overdose squad that will look at all the fatalities and look at the doctors who are overprescribing. It's always been a dangerous drug, but now with the synthesization of fentanyl, it really is Russian roulette. Fentanyl being 50 times stronger than heroin. It's Russian roulette. When you go out and get that bag, there's no quality control. And what it is people's lives are in the balance. There's several bills in the legislature. I know the Attorney General has one, Representative Fernandez has one with regards to drug trafficking, lowering the numbers to include fentanyl and the mandatory minimum sentences with it. I was a defense attorney for 17 years. I believe in compassion. I believe in treatment. I believe in getting people's beds. We've got to have better laws. We've got to have better access to treatment. We need everyone to understand, to remove the stigma, to understand that the addiction is a disease. Would we ever turn anyone away with heart disease or cancer at a hospital door? No, we have to find beds. And it isn't a quick recovery. Relapse is part of the recovery. I support the governor's legislation. I know we're waiting on one other DA, but all the DAs so far support the governor's legislation that would empower your police chief, empower doctors on a weekend to help get someone committed under Mass General Law 123, Section 35 for the weekend. 72 hours, have them locked up and treated in a secure treatment facility rather than having to have Chief Woodson in your police department have to Narcan a guy 2 or 3 times during the course of a day once they're deemed that dangerous because of alcohol or drug use. I want to thank you for the invitation. I want to thank you for the attention to the problem, and if there are any questions, I'd be happy to try and answer them.
Does anybody specific have questions?
If not, Gus, I'll
Good.
just wait. First of all, thank you. Appreciate you being here today. I would imagine you're seeing the level of people in jail is rising as a result of low type of drug addiction, right? So in terms of the penalties and legislation you'd be supporting in front of the governor's office and through the legislature, are you looking for some way to deal with that issue? In other words, keeping people out of the prisons and more into the treatment centers. How are you making that conversion, and what steps do you think the state government is taking in that area?
A couple things. One, from the prevention end. I'd much rather prevent a crime than have to solve a crime. I like what the governor's doing. The governor came in and talked to us, and he told us he wouldn't allow his boys to take a Percocet when they had a wisdom tooth out, because one pill can be a game changer. Recently, I was at the prescription drug abuse seminar down in Atlanta, Georgia, and the secretary of the, you know how doctors are. I don't want to stereotype, but they don't always want to give you everything. But they said they're 95% sure that they have identified an addictive gene in people and a non-addictive gene in people. So can you imagine with a pinprick and a drop of blood, they can tell you whether or not they can give you opioids or that the risk is too great. With regards to drug users, we don't have a lot of drug users in jail. We have a lot of drug dealers. We have a lot of people who do ancillary crimes such as B&E. I believe in compassion. I believe in treatment. There's so many different ways. I mentioned people are getting smarter, but they're also getting smarter with regards to treatment. With regards to Gloucester, you see some things happening up there. You see it happening in different parts of the state. You know, if it works, I think we have to look at it because the problem is just so prevalent. The problem, one pill, and I think the governor's right, one pill can be a game changer. One pill, but our office, I tell our ADAs, show compassion on drugs and alcohol, but stay within the law. If you can get them treatment, get them treatment. We abhor violence, we abhor B&Es, but with regards to the user, if you can get them some type of treatment, try and get them treatment, try and help with the problem.
Terrific. Thank you.
Thank you. Actually, I do have a couple of questions. Do you find that the prescription drugs are actually getting stronger? You've made reference to a couple of them a couple of times so far. And also, where's the strongest illegal stuff coming from?
Purdue Pharmaceuticals, when they came out, told us that OxyContin was non-addictive.
Right. They lied.
So where we've gotten from there is, you know, we've got the Hal Rogers grant. Two of my fellow DAs have been fortunate enough to get it as well. And David Sullivan out to the west, Michael Morrissey to the southeast. And what they found, oftentimes, OxyContin is our most powerful now, right? But there's a hedge, which the FDA said don't approve, but has been approved, is going to be even more powerful. What he's done and what we plan on doing is taking all of the overdose deaths, as I mentioned, find out where they got their last prescription, go into the prescription drug monitoring program, finding out why and who are giving them that many prescriptions over a period of time. What we're finding out is, I heard it mentioned earlier, and I think it was from Maura Healey is doing a lot of good work, as well as the governor, with regards to this. We're 5% of the world's population, yet we use 95% of the world's opioids. I mean, basically, I think in a lot of ways it just comes down to dollars, and that's shameful. But I think the best way to fight the problem, the best way, is to get the kids as early as age 5, 6, 7, and 8. That's why we're in the schools. Prevention, 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 and intervention. That's why we have diversion programs. You know, we have kids, we've used it with regards to alcohol right out here. We've had them down at the Armory or wherever, giving us 8 hours of community service, fixing up ball fields. My philosophy is you keep kids busy after school around responsible adults, it's a plus. They're not at home, but between the hours of 3 and 6, latchkey kids getting into the medicine cabinet, things like that, the prevention, I think, are really the way. You want to see numbers go down in the jail, that's the way we've got to do it, is the prevention, education, and intervention end.
Do you think there's any way that we could, as a society, do a better job of teaching parents to parent to help get that issue into the homes themselves?
You know, we're doing that. I mentioned the movie Hungry Heart, and one of the biggest things is, you know, on open houses, we know we got to be careful because they're coming in on open houses, going right up to the medicine cabinet. Looking for the pills. We've got to make sure that people know the drug take-back days. As part of the Hal Rogers Hal Rogers grant. There are boxes, take-back boxes within the county, but we've got money for more. We've got money for more Narcan. But absolutely, the parents have to be better educated with regards to the risk. Your kid gets sent home with 60 pills, 60 Percocets for a wisdom tooth. You've got to ask the questions why. And you've got to monitor what they're taking. And the second the pain is at a point, or if you know you got an opiate problem in the family, oftentimes genes play into it. Say to the doctor, can you give us something else? Can you give us, but the education has to be, because so many parents talking in pain, and I've often been asked, what's the worst part of my job? And it's talking to people in pain. And so often they said, we thought he did a little bit of marijuana. We thought he drank a little bit, but we had no idea. He was using heroin. And when you can get heroin now, basically, and that's where they go, from the prescription drug to the OxyContin at $1 a milligram. And when that money runs out, they get the heroin bag for as little as less than the price of a Happy Meal, $4 or $5 a bag. Yeah, so the education has to be there at every level.
Thank you. Councilor Clements?
Yeah, you've sort of touched on some of what I was talking about, because what I'd heard in your earlier conversation was we have to crack down on the doctors with the extensive drug prescriptions. And while I don't disagree to making sure that everyone is following the same protocol and using the systems that allow them to know where these patients are getting their various prescriptions. However, in my conversations with numerous physicians and such on this, including ER-type doctors and such that I've spoken with directly, a lot of times it is the medical community that gets the slap down, because they're prescribing something for pain. People come in with legitimate pain, and the pain needs to be addressed. And if they don't give them something, then they're accused of not taking care of them. And if they give them something and explain how it's supposed to be taken, and then they go home and do not take it the way it was explained to be taken, then they become, again, the villains. Because, and I'm not saying you're wrong, because I understand, I've seen it happen. I'm just explaining the conversations that I've had out in the community also. And I think education, you finished up your conversation with more education from the medical professionals to the patients that they're getting, more education early on, more education to the community at large, so that people know when they go and see their doctor, they might have a choice. Because a lot of times you don't think you have a choice. You're afraid to speak to your doctor. There's that little intimidation perhaps, or you're in the ER and you don't know any better. So while I agree with a lot of your statements, I was concerned with some of your statements because of hearing from the medical community. And it would seem that if there are going to be more mandates and more options for getting treatment, which is wonderful, I think, again, we need to support the medical facilities, the medical options that are out there, whether it's through state more funding for these facilities to be able to educate more, because it costs money and it takes time and it's valuable. And while we're trying to see hundreds of people in the ERs and such on a daily basis with lots of conditions, it's a double-edged sword sometimes that they face. So I guess I was just advocating for the fact that I agree that there are many out there that don't do what they're supposed to, but there are so many more that try to just help. And unfortunately, you're damned if you do and damned if you don't. So.
Yeah, and in no way, shape, or form am I trying to give it a general condemnation of doctors. I've got some doctors in our family that's some of the best. I think in government we can always make it better. And so often what you may not know is that when we get an overdose deaths, the doctor doesn't find out that his patient died. And I think people want, whether it's the pain scale or it's all the different things, so many doctors do such a great job. I just think there's another component to the governor's bill on the 72 hours, except in instances of chronic pain, where you administer the medication. I just think by getting better on it, it's going to help with the problem. It's such a crisis situation. And one of the things that I remember Dr. Hirsch in Worcester, who's the head of the Department of Public Health, said, sometimes we're guilty of it. A guy's in on a Thursday or Friday, and do you give him 4 Percocet or 4 pain medications, or do you give him enough to get through the weekend? And he acknowledged that's where they could get better at it. And I think in no way, shape, or form am I giving a full-blown condemnation of doctors. I just think in government, as my father used to tell me, we can always get better. And I think getting better means getting a little bit smarter. Thank you.
Anybody else have a question?
Yeah, just a quick question. So in the instance where you found that gentleman that you spoke of, where the police came and gave him the Narcan and he popped up, he wanted to go to the ER, if he didn't want to go to the ER, what happens? They just let him go?
We got a problem. We got a problem. We've done a couple Narcan trainings, but the police are trying to do everything they can to persuade them to go. They give them the statistics. Hey, look, we gave you Narcan, but it might only last for 20 minutes. It might only last for 40 minutes. This high can last for 6 to 7 hours. So they, as persuasive as they can. What we know on the statistics, and some of the things that have had to have been removed, 60% of the time, they're going to give the right amount of Narcan. And the person is going to be, and the way it works is it blocks the, if this is the receptor, it blocks it. And the respiratory system comes back, they start breathing, the heart rate increases. Roughly 16, 17, 18, 19, 20% of the time, they give too much and the person goes into withdrawal, which they can get sick. You know, they can start vomiting, they can show those signs. Or 20% of the time, they don't give enough and the person's actually a little bit groggy. But they can't compel the person to go to the hospital. But they do everything they can, which makes their jobs that much tougher. It's that hard to be a police officer right now. It makes it even that much tougher to get them to the hospital. But they are very persuasive.
And so just as a follow-up, so under the legislation that's been proposed where you can forcibly put somebody into a facility, will that tax our facilities?
I think that's going to be a great question, Rep, for you guys in the legislature. I think yes.
Well, I'm just asking your opinion.
I think the short answer is going to be yes, but hopefully if we're successful, the numbers are going to go down.
Right.
But we need more beds. We need more facilities. Yes. The short answer is yes. The short answer is in the short term, it might cost us more money to do it, but morally as a society, don't we have that duty in it? But I think in the long run, it's going to save dollars if we get that much better with regards to the problem.
Okay. Thank you.
Okay. No,
thank you, Mr.
you.
Chairman.
You're welcome. Actually, I do have a follow-up question to that. Do you have any idea, any evidence of how many beds were short and what we actually need?
I don't, it's just anecdotal. I do know that the governor has pledged to do everything they can. For example, not to on that lockup, not to put people in prison facilities, not with people who have committed crimes or have charged with criminal acts. With regards to women particularly, there's a Taunton hospital, and I believe a Brockton perhaps hospital, not to be sending him to MCI Framingham, but getting him into secure treatment facilities. I don't know the numbers actual numbers on beds, but I know that is one of the real issues.
Okay, thanks.
Thank you very much for coming tonight.
No, thank you.
Thank you. Come on here and let me shake your hand. I really appreciate you coming tonight. Thank you very much. Thank you.
Thank you. Thank you. Thank you. That's a good point.
Okay, as we move on, we have a representative from the Sheriff's Department who Town Manager will introduce with a bio and then moderate the section.
Terrific, and thank you, Subcommittee Chairman Vecchia. We appreciate it. It's my honor tonight to present to you a representative from the Worcester County Sheriff, Lou Evangelitis' office. The person that is going to be representing his office is Nick Barbara. He is a graduate of UMass Amherst Suffolk Law School, ADA Suffolk County DA's office for 3 years, FBI Special Agent, Supervisory Special Agent for 21 years. Also, WCSO for 4 years, and Assistant Deputy Superintendent in charge of investigations, currently the ADS of external programs. I want to welcome you, Nick, and appreciate you, Representative Sheriff Lou's office tonight.
Oh, thank you so much, councilors, Mr. Representative. I really appreciate being here. And I'm going to take this time to explain the sheriff's role in this crisis. Our main responsibility in this county is the House of Correction, which is straining to the breaking point because of this. We have 1,100 inmates. 90% have drug and alcohol problems. They are there because of drug use, and frankly, we're hoping to reverse that. As to prevention, so when we took over the sheriff's office in 2011, there was actually a drug problem at the jail. There was a lot of contraband coming in. So we had several meetings, and we decided to take some really positive steps to stop that, because we said, if these young men are here in jail, they shouldn't have access to these things. This is their one real chance to detox, if ever. So we took the steps we took. We started a canine program, so we have drug detection dogs on site. They didn't have that when we started. We bought a $250,000 body scanner because the most prevalent way of getting drugs in would be for the inmates to secrete it on their body and smuggle it in that way. So this body scanner is state-of-the-art, and it's really worked very, very well. We have a rigorous drug testing program now. We're with 2 COs, 2 correctional officers are dedicated to that every single day. They're going around and testing these different inmates. I took over the mailroom personally. I was the director of special services, which is all investigations when I started. And the mailroom, the drugs would come in through the mail. So what did we do? We would bring the drug detection canines to the mailroom so that they could detect, alert on the mail. We also put a correctional officer in the mailroom with the civilian staff, and we've been able to find just some amazing attempts to mail in drugs. And we also stopped contact visits. There were a number of different areas in the jail where people could come and visit, and it would just be face-to-face, and there would be all kinds of smuggling. So we've really made a huge dent in that, and that's something I'm personally proud of, and Sheriff Liu has really spearheaded that. Also at the jail, we have a very, very aggressive program. If an inmate comes forward and he admits to being addicted to drugs, we try to put him into this specialized program where there's mental health counseling. They're educated on the dangers of drugs. And we've had several of the inmates who were ready for parole actually refused to be paroled because they were doing so good in this program, and they stayed in. We've also tried to educate the community. The Sheriff Liu has started a wonderful program 5 years ago, face-to-face, and it's been here in Southbridge. He goes to the middle schools, he goes to the junior high schools. It's a multimedia presentation that I encourage anybody, if you hear where it's playing in one of the schools, to go see. And it basically, it really it pretty much scares the kids about drug use. And it's just a great educational tool. Now, one thing that we've come to realize, and the Gloucester chief would often say, he often says, we can't arrest our way out of this program, out of this problem. And the sheriff says, we can't incarcerate our way out of this program, out of this problem either. So we've taken some really serious steps to limit recidivism. If you leave the prison and you start taking drugs again, the chance that you're going to be in jail again is 90%. The chance if you're out there after serving a prison term and you don't have a job, the chance of you returning is 86%. And we just can't have that. But basically, we have these young men start to serve a life sentence 2 years at a time for over many, many years. So we're trying to reverse all that. Now, one aspect that we believe in are the different drug courts that are popping up. And they're late in coming here to the Commonwealth. They started, believe it or not, they started in Texas. And what is basically a drug court is a number of different things. And sometimes they're hybrids. But it's basically intensive probation. It's an intensive probation program. And we've jumped in and we've tried to, and we have aided the different drug courts. There's one in Dudley, and there's a center that we run. It's the Regional Resource Center in Webster. I'd like to point that out right there. That's the front. It's on Main Street in Webster. We took a deserted building that had been part of the trial court, and we beautified it, and we put in $500,000 to run this center. So it opened in February of 2015. We currently have 200 clients. from the drug court that go there. So there was an open house in April. In September, we had 133 clients, 30% from Webster, 16% from Dudley, 10% Oxford. And we forged various partnerships. Workforce Central is an employment readiness entity here in Southbridge. They've been tremendous partners. We are really dedicated to seeing that these people are employed. So they help with resumes, they help with job skills, they help with interviewing skills. Harrington Behavioral Center is our counseling. Greg is here, he's going to speak, I believe, after me. And they have been a tremendous partner. They're very skilled, very skilled clinicians. We partnered with a junior high school. These students come in and they speak to our counselors, and they're going to do some landscaping, and we're hoping to put together a victory garden there at that center. Nichols College is doing some of our statistics, and then we have spiritual support with one of the local churches. There's lab testing, that's a main feature. We have state-of-the-art testing. People come in and they're drug tested. And there's also breathalyzer for alcohol. We have an education piece there, high set preparation, so we have a number of the clients come in and they don't have a high school diploma. And we will educate them as best we can. We also have computer classes. Case management has been a very important part of it. We have 2 case managers. So we'll have a client, and they have a number of different things going on. They have a mental health problem, they have an addiction problem, they have doctor's appointments to go to, they have interviews to go to, so the case manager will keep track of everything for them. They'll help them with their mass health paperwork, they'll help them with Social Security disability if necessary. It's really, we'll do everything to facilitate them staying out of jail. There's a beautiful community room, and we use that for different groups like NA and Alcoholics Anonymous. The pastor, Janice Ford, leads spiritual groups there. And we also have a wonderful group that comes in, Learn to Cope, which are parents who've lost kids to addiction. And we like this center, especially because it does have a community feel. And that's important, I think, for anybody in recovery, is to feel that the community is supporting them. There's our community garden that we did with the junior high students. Basic computer skills, real nice classroom that was put together by our IT division from the sheriff's office. And this has been really important, transportation. So we have a van that does a loop. There's very poor bus transportation, public transportation in this area. We listened to what the drug court needed, and they said, we need you to help us get people to appointments, get them to your center for testing, and we've done that. We've tried to do that. We're going to try to expand. We've applied for a grant that will give us a second van. Also in the lines of curbing recidivism is we've put together an after-incarceration support service. I'm part of that. I will interview all the inmates who are leaving. I'll find out what plan they have in place, where they're going to live, do they have a contact phone number. We have an office on Main Street in Worcester. We assist all ex-offenders to successfully transition back into our communities, if that means a GED class, if that means interviewing skills. We'll refer them to mental health counseling or to drug counseling. And so there's the list of services with the after-incarceration support is housing. We have housing contacts. We don't want these people to be homeless. If you're homeless, you're more likely to be rearrested. We work with their employment. We have a job developer on site. We also have centers in Fitchburg and in Worcester as well as Webster. There's a healthcare aspect, mental health, aftercare and treatment, and substance abuse. Aftercare and treatment. So thank you. I'd like to echo a lot of the things the DA said, what the chief of the Gloucester Police said, as this is not a crime problem, although it does lapse into crime. We see that the people who become addicted start to steal from their family. Once the family throws them out, they will steal from the public, and then they go to jail. Thank you.
Thank you for the presentation. Just a quick question. Start off, very interested in your after incarceration program, right? So I imagine that's not court ordered for someone who's leaving prison. What percentage of your, I guess, people who are leaving the prison system are getting involved directly in that program?
I would say about a third. We have worked really hard. We don't have a hook. And sometimes these people, they're free, and the last thing they want to do is see me.
Right.
So we make sure we have a contact number, we contact their families, we have bus vouchers that we can give them, we have clothing that we can give them, and we really stress the extra effort to keep them coming back.
So once one of the prisoners leaves your system, let's assume they don't take the program right away. After 3 or 4 months, if they run into a problem, can they come back into the program?
Oh, absolutely. We have a complete open door policy. Complete open door policy. That office is open from 8 to 4. Myself and my assistant, we often give our cell phone numbers to these folks. And there's also, the female inmates serve their sentences in Chicopee, but they have access to this center as well.
Terrific. Thank you. Any questions from the panel? Chairman Moriarty?
Sure, just briefly, considering many facilities such as yours offer counseling, as you've referenced, but oftentimes with those coming with that is the incentive of kind of good behavior and kind of time off that punishment. How can you handle or how can you prevent people from more or less trying to abuse that privilege or that offer in terms of going through the motions? And because I know that it's in often cases, it's very highly coveted to get into that sort of program based on the amount of resources your office has. So how are you able to differentiate and prevent somebody who is doing that more or less to go through the motions in order to get out quicker than somebody who might actually have an interest and a desire and a drive to kick that habit?
That's a great question. There is a great level of trust, and you have to trust the inmates who put themselves into this position to a certain degree. But there is leeway for the counselors, and they are pretty savvy individuals. They're all very experienced, and they will weed out those inmates that they believe are just faking.
Okay.
Yeah, thank you.
Councilor Steves?
How long do you actually follow up on these people after you've let them out?
I'm sorry.
How long do you follow up on them to make sure that that what they're doing is working?
Oh, you mean the after incarceration care? Well, if we have a good contact number, we'll continue to call it for a couple months, and then we have to give up because it's just the numbers. Luckily, we have a lot of people leaving the facility as well as coming into the facility.
Any questions? Representative
Just one
Durant?
question. What's the recidivism rate of these folks who go through that program? Are you seeing good success?
Yeah, I don't have a precise number.
Anecdotally?
But anecdotally, yeah, I could tell you I went to a gas station in Worcester and I had somebody come up who recognized me and thanked me.
Yeah.
And, it was pretty nice. I don't know how completely clean he was, but he was certainly employed, and that was a good sign.
Yeah, I think I think the sheriff's office is doing great work, and I think some of these outreach programs are working out very well. The van? I didn't know about the van. How's that work? That's for people in the program just to help them get around?
That's right. We'll go. The Webster Center is about 10 miles, maybe less, from the Dudley Court. We'll go to the Dudley Court and pick them up. We'll take them to Harrington, to the hospital. We'll take them back to the Webster Center so they can be drug tested. And we're starting to make trips to East Brookfield as well, to that district court, where there's really quite a problem. I went there. We're starting to do some work with the probation department there, and that court is just jammed, overflowing with defendants.
Any other questions?
I'm all set, thank you.
We're all
Anything else?
set? Okay.
With that, I want to thank you. I appreciate already we've developed a relationship. We're going to be working together on some issues. So I appreciate you coming here, and please pass on our appreciation to Sheriff Lou as well.
Okay, absolutely.
Right
Thank you so
back.
much.
And
I get a handshake?
there you go.
All right, as we move on, I'm going to introduce our police chief, Woodson, our deputy chief, Dingy. Is he there? He can come up. Officer Dingy, you can't hear me? Can you come up, please? Also, Fire Chief DeFonso, and also Chief Woodson, you have the Bay Path representative. Can you put him in with you? Where is he? We have a guy from Bay Path that you, there he is. Okay, thank you very much. I'll hand it over to you, Chief Woodson.
Good evening. Thanks for having us, Councilor Vecchia. Just kind of want to touch on the history a little bit of why I would like our department to institute the Gloucester program, or develop a program at least similar to the Gloucester program. In 2014 in our community, we had 24 overdose cases. In 2015, up until today, we've had 33 cases. What's alarming is, towards the end of September and through the whole month of October, we've had 11 overdoses alone, just within that month to month and a half time frame. Out of those 11 overdoses, 2 of them have been deaths, and there's a third death that's being investigated now as possibly being an overdose, but it's still under investigation. Everybody here, I'm sure, and not speaking for everybody here, but we've all had friends that have died from this disease. I personally have gone to high school with several people who have become addicts and have passed away, and they're only my age. Several of them I know now, and they're living on the streets as addicts in the bigger cities. So it really hit home with me. So with that said, a few months ago, I'd kind of been checking in on the Gloucester program, and the Angel Initiative is what they call it. And I thought, that's a really good idea. We have a similar community. Gloucester's a little bit bigger than we are, but we have a very similar demographic. So I called the chief, Campanella. I wish he was still here so I could thank him. He was kind enough to meet with me for several hours at his police station. In fact, as we were sitting in his office, we were actually waiting for an intake to come in, because he had told me that almost every day in Gloucester under their program, when an addict comes in and needs help, they call it an intake. And he had said, Chief, you and I can go downstairs, we'll walk through the whole intake process, just so you can kind of see what it entails. Unfortunately, there was no intake, so he kind of explained to me the whole process on it. I said, again, this is a great idea for Southbridge. What he stressed was, you need to get the town of Southbridge involved, the councilors, other politicians, the state rep, the fire department, the citizens in the community. He said, or this program will not work. So I had told him, and I was speaking with Councilor Vandal earlier tonight, I said, the good thing about our community is we have councilors that are very invested in the community, and they care about the community. So I knew it would be an easy sell, so to speak, to the council, because we've always been proactive in this town. The police, the fire, the council, when there's an issue, we get involved in it, the school district, and we deal with it immediately. And I respect that, and that's how we run our department. So with that said, I'm driving home and I'm thinking about all the things we can do in Southbridge, similar to Gloucester. And within a few days, strange timing, Councilor Vecchia had called me, and to his credit, he said, listen, Shane, I want to do some kind of forum in the community. Opiate use is out of control. It's affecting a lot of people. It's affecting a lot of people that he knows personally. I said, well, Councilor Vecchia, that's pretty funny, because I just met with the pioneer of the Angel Initiative in Gloucester, the man that created the whole program, and I'd like to introduce it to Southbridge. So strange timing, good luck, whatever it was. Councilor Vecchia said, let's set up a meeting, let's get it going. I want to do a forum. I want to get it out there. And I said, that's great, because I need to get some kind of venue where I can present this to the community. Within a couple days after that, Councilor Vecchia called me again, said he had arranged a meeting. It was either Councilor Vecchia or the town manager, Mr. Santangelo. We had a meeting a few days later. The chairman of the council was there. The first thing the chairman says is, hey, listen, I've been thinking about the Gloucester program. And I said, again, to Councilor Moriarty, That's pretty strange because I just met with the Gloucester chief 2 days ago, or 4 days ago, whatever it was, and I think this would be a great thing for the community. I kind of explained and touched on the highlights of how we would want to institute it, work it into our community. It doesn't have to be exactly like Gloucester. I know other towns out towards on the East Coast, towards Boston, Arlington, Methuen, Newton. I've kind of been following them on their webpage to see how they've been rolling out the program. And you can tweak it, for lack of a better word, to suit the needs of your community. So it doesn't have to be exactly like Gloucester, but it can, you know, some variation of Gloucester. After talking to Chief Campanella, I was a little bit concerned originally about the program because I'm one of those guys that's tough on crime, and it is what it is, and you do the time, and I was a little worried that maybe that's what this program catered to, and it's not. That's not it at all. Chief Campanella and I have similar backgrounds, very, very similar philosophy on policing. I agreed with everything he had said that day. He sold me on the program. That addiction, it's not a crime. You know, it's a disease. And for the last 20 years of my career, and I know the deputy and I have spoken about this, what we've been doing has not worked in policing in general, not just in Southbridge, but nationwide. Treating addiction as a crime, it's just not working. It's an enormous amount of money. It's a stress on the system that's not needed. There's got to be a better approach, and I believe the Gloucester Initiative is that approach. Along with working with the Police-Assisted Addiction and Recovery Initiative, which Gloucester Chief assisted in co-founding, I think we can get something done. We can save lives, very important. We can also reduce the number of addicts, which in turn reduces the demand for drugs, which puts some of these drug dealers out of business. So we're not going to be soft on crime and go easy on the dealers, but within the near future, with the help of the town council and Councilor Vecchia and the town manager, we fully intend, the deputy and myself, on rolling this program out. Over the course of the next several months, we are going to put the wheels on the ground and get this going and see where the rubber meets the road. And basically, we're going to devalue or attempt to devalue this endless supply of heroin that we seem to have, you know, throughout the community. And not just Southbridge. This isn't a Southbridge issue. We've got a chief from Webster here. I spoke with several chiefs in the area. There's a lot of issues going on in all of our communities. It's not unique to us. With that said, and how I think this program will be such an enormous success, I got to say, and he's probably going to be very upset with me for calling him out here in this meeting, but Mark from the Spectrum House, wherever he is, yes, there he is. 3 days ago, a detective came to me and said, hey, Chief, we've got an issue. I've got an addict that contacted me, and he needs help, and he needs it today. Now, 20 years ago, we would have said, okay, call this 800 number, and it would have been 7 weeks before there was a bed available. So I called Mark, and I said, hey, Mark, we've got a guy here. We don't have all the program refined yet. It's really not in place, but he's an addict and he needs help. What can we do? So Mark and I was actually shocked, and that's how I know this is a turning point in how we treat addiction. He said, you know what, Chief, give him my cell phone number, have him call me directly, and I will find some place for him if he needs it. I had to ask him again. I said, do you really want me to give him your cell phone number? And he said, yes, give him my cell phone number. And he repeated, we will find him help today if that's what he needs. So I was impressed by that. Actually, I was shocked, just, you know, driving home that night thinking, this is where we are now with what we're going to do with this program. If we've got people like the Spectrum House, great neighbors in our community, an asset to the community, if they're willing to bend over backwards, and they are, because they've showed it on that day, where you've got employees giving out their personal cell phone numbers to people who are addicted and need help, I think they should be applauded for their efforts at the Spectrum House. And I look forward to working with them, partnering with them in the future. I know there were several people here tonight, and I appreciate them coming down and supporting the cause. I appreciate the council moving forward with this. Councilor Vecchia for having the forethought to say he wanted to get something done. He wanted to get a forum together, and Councilor Moriarty, the chairman, and it just kind of all happened at the right time. I think it's a great idea. We will, and I'll keep everybody posted on what's going on as far as how we're going to set it up as a policy. We're working hand in hand with the hospital. Our deputy sits on the board up at Harrington. They're a great facility, great for the community, and they have basically agreed to help us out in whatever way we need. I also wish District Attorney Joe Hurley was still here, because I'll tell you, there's never been a time in all my years in law enforcement where I called that man or any member of the DA's office and they said no. They answer the phone anytime I've ever called. They've always devoted resources to us, and I greatly appreciate their efforts with this cause. With that said, so you guys don't get sick of hearing me talk, the fire chief has some other information on Narcan. He's a little bit better versed at it than I am, so I'll turn it over to him.
Thank you, Chief. You know, this community and this council certainly has invested a lot in public safety, especially in 2006 when they took a vote to go to the paramedic level to provide the highest level of care that we could give to our citizens in this community. It came to true fruition in 2008 when we really got to the medic level and were able to provide that service. So while the chief just mentioned some numbers from 2014 to 15, you know, it doesn't sound like a big number, but we actually went back to when we were starting to do our records electronically so we could pull some cases. And in 2010, we only had 10 cases of overdoses that we could find. So today we have 33. So in 5 years, we tripled the amount of overdoses that we have here in this community. That's a significant jump. And with that significant jump, and while we are at the paramedic service level, and we were able to carry Narcan right when we went to the medic level service, we can't make every call. Our call volume is so high that, you know, I can't guarantee an ambulance to every single call that we get. So when Narcan became available for the first responders to have, I approached the police department and said, hey, you know, this is something I think you really need to look at. While we're a great service and we're there, you know, over 95% of the time, we make every single call from 911, there will be that rare occurrence where we may not make it and we have to wait for mutual aid ambulance. So they took a look at it and worked with their staff, and their staff stepped up and said, yep, sure, we'll take this initiative on and we'll start to deliver the nasal Narcan. And I think it's a great program that, you know, first responders can give nasal Narcan in those cases where we can't get an ambulance there in a reasonable time, and these guys have the training and ability to do that, to stop that, you know, high from that person, and we can bring them back from not breathing and not having a pulse rate. So I really want to applaud the police department for doing that. And I also want to applaud our staff and the council again for, you know, again, taking the time to listen to the public safety agencies and give us the tools we need to provide the citizens the services that they deserve. Because it's a lot of investment that you guys have taken to put in us and in the police department to provide that to the community, and that does not come cheaply. So I just wanted to say thank you for that. I also wish the AG's office was here as well, because you know, if it wasn't for them, Narcan, as you've heard, is skyrocketing in price. So again, that comes down to us as the service providers and you guys as the, you know, people that hold the money. You know, we got to pay for that. So they were able to keep Narcan at a very low cost and work to get some monies put into a fund that we can utilize if need be to, you know, purchase Narcan at a very reduced price. But again, we're very price conscious in our department, and Harrington has always been a great partner for us. And so far, the costs have been very small for us to keep going with Narcan. So I'm sure we'll keep working with Harrington to make sure that we can deliver all of the necessary medications to include Narcan to the citizens of our community. So I just wanted to say thank you to the AG's office for continuing to work for that. So that's pretty much all I have, unless people have questions of me.
Chief Woodson, could you introduce that man from Bay Pass and let him speak? The Bay Pass guy.
The vice principal.
What's his name?
Hi, Dan McGowan, Dean of Students at Bay Path. Thank you for having me. It's honestly a privilege to be here tonight. Being in education, I feel like I've gained in education just by simply being here this evening, because there are so many foremost individuals here that have a lot to offer in terms of education, programs to offer for our students to maybe take advantage of. Fortunately, at this time, Bay Path hasn't had a documented case of opiates, but I would be foolish and naive to state that we are, beyond reproach of such a disease, and it truly is a disease. It just means that we haven't had a documented case. I'm sure that there are individuals that are somehow affiliated with our school that this disease has touched. Hopefully we can reach those individuals before it becomes some kind of a tragedy of sorts. I, just like the DA early, believes that we got to reach them young, and the younger the better, to be able to educate them about the dangers that are involved in these types of things. I don't have to go very far to realize some of these dangers. As one of our earlier speakers noted, my own family has been touched by such a disease. This was long before Narcan was something that was widely distributed or available. Unfortunately, she's no longer here with us tonight. So with that being said, there is at least while I'm as an administrator at Bay Path, and I know my administrative team at Bay Path supports not only myself, but we are a unified, solidarity effort to try to keep Bay Path as clean as possible, regardless of which of the 10 towns that we receive students from, whether it be Southbridge, Webster, Charlton, Dudley, or any of the other 6 that I haven't specifically mentioned. And I just want to echo one last sentiment that, anybody who believes that maybe their town, their school, their family hasn't been connected to such a thing as opiates and thinks that they are beyond the scope or the reach of this type of a disease, they are fooling themselves. They are naive to say such a thing. And they're eventually going to, find out or figure it out the hard way, unfortunately. And thankfully for the people that are here this evening, thankfully for Chief Woodson, which I want to thank for inviting me. It's a pleasure to be a part of this program. We're going to hopefully, hit the road running and be able to make a dent in this disease and to remove the stigma that has been attached to such a disease. Thank you for having me.
I don't think Dan knew he was giving a speech tonight, so nice job.
Okay, I'll entertain questions to the fire chief and the police chief and the deputy chief. Go ahead.
Sure. So more so to the police, but if Chief DeFranzo has anything, by all means. What do you've both been involved in town in a number of levels for a long time, and you're from here and so forth. What do you view in terms of adopting that Gloucester initiative to Southbridge? What do you view as the biggest obstacles to overcome? And ideally, or more importantly, I suppose, which of those obstacles are things that the council can work with you and help you overcome?
There's a couple of issues, of course, as everybody knows, probably better than I do on that stage. Finances, we'll have issues where I'm sure we'll get, once we roll out the program and we publicize it, we anticipate a large amount of people that are going to be needing help, and that's great. We don't want to turn anybody away. So if we don't have a local facility to bring them to, we may have to transport them to a program similar to like an AdCare in Worcester, which clearly has its problems because we'd have to tie up an officer, the half-hour drive, however long it takes to process, and then the half-hour drive back. So we're working on that by working with partners in the community like the hospital and the Spectrum House, and if we can avoid having to actually leave town, that would be a wonderful thing for the program to make sure it's successful. Either way, it will be successful. We will make it work. Chief Campanello had told me earlier tonight, actually, that there's a bunch of funding coming from the federal government for programs similar to this. So once we get up and running, if we run into issues with cost and overtime and transports, and I think we'll be able to work on that at hopefully a minimal cost to the town council. Another avenue we can pursue is, and again, Chief Campanello, this is not my idea, he had suggested using state and federal drug seizure money, which, unfortunately in our community, we get a lot of that. So if we have to redirect some of those funds to this program, we'll do that to minimize the cost of the town. But we don't want to turn people away. If you need help, I believe local problems need local solutions. And if we can make that happen, we're going to make it happen one way or another.
I think the other thing would be is, like we've heard tonight, the word stigma. When someone does show up and they are requesting help, we need to give it to them. And, everybody thinks the police are the bad guys. They're not. They want to help. Sometimes they have to do a difficult job, but I think for the most part, they really want to help every single solitary person who needs it. So I think the stigma of, hey, if you need some help, talk to any public safety official. Make sure you guys are approachable. So, because maybe they don't want to come to talk with us. You guys should be approachable as well. So if they feel comfortable talking with you, then you can get them the help. But I think the more people that we can get educated that everybody in this community is here to help you, just ask for it and we'll do everything we can, I think is going to be huge. So education, I think, is going to be a key component.
And if I could, Mr. Chairman, what's great about this community is we always take a hit. It's always a negative, a negative, a negative. We had an incident today at the high school. Oh, Southbridge again. No, there's a lot of positive things going on in this community, and a lot of departments work well together. Police, fire, DPW, the schools. and whoever else, the hospital, and Spectrum, and the council, and we can get a lot done as a group effort. This will not be a one-man show. You know, we're not on an island. We're going to get a lot of contributions from a lot of people, I anticipate, from what I'm being told anyway, and what we're being promised. And I think we'll be able to overcome a lot of those obstacles just on the teamwork, you know, and the positive things and the great people that we have working for the community. They want to be here and they want to help the people in the community, and this is one way to do that.
Thank you. Councilor Clements?
Thank you. A couple questions. Again, we hear the stigma, we want to get rid of that, and the idea of calling someone an addict or a junkie or those types of things. What are we doing in-house, or what type of training is being offered to our officers or our firefighters and such in terms of using the more acceptable term of, substance use disorder, those types of things? I mean, are we really making sure that we advocate for that within our forces here? I mean, is that something that's coming from education?
The issue that the chief in Gloucester had was getting his men and women in his police department to buy into it, especially some of the more senior officers that have been around for 20, 30 years. And he said they got over that issue rather quickly once they saw that it was working. So if you get some people that aren't buying into the program, we'll develop the policy, we'll draft the policy. This is what you have to do, A, B, and C. But we'll meet with every single officer face-to-face in that building, and whatever their concerns are, they can tell, they'll talk to us about it. We'll make sure we go to every shift, we'll explain what needs to be done, and if they have an issue, I believe, between the deputy and myself, we have relationships with these people, our staff, well, they'll be honest with us. If they don't think it's going to work, well then, tell me why you don't think this part's going to work, and then what would you do to resolve that? Because, contrary to popular belief, the chiefs are not the smartest people. We're not the only people that are smart in our building. So if someone has an idea that can maybe help the program that maybe we didn't think of, we would welcome that. And not speaking for Chief DeFranzo, but we'll have a similar approach because we've talked about it.
Yeah, no, that's good, because obviously, one of the problems we have often the police officer, the firefighter is the first face of customer service in this community, that the
Right.
taxpayer or the resident or whoever it is that's visiting us and needs emergency services or any type of service. And so many times, we'll get feedback of not just, it happens everywhere, as you know, stigma that goes along with the police jobs these days and such. But certainly we would need to enforce that, obviously top down, making sure that it goes both ways in terms of understanding that program.
We will consciously work at doing that because, again, people that have implemented this program in the past have had a few minor glitches. People don't like the new things, and anything new is going to be certain people will shun it and turn away from it. But once you see what's going on, you see the progress. In Gloucester, I'm not sure if Chief Campanello elaborated too much, his breaking and entering, the cars and houses went down like 35%. In a 6-month stretch, because all the addicts that are committing these minor offenses to fuel their drug habit, they're getting help now. Right. So I'm not saying it's a miracle and it's going to work overnight and it's a panacea and a cure-all, but it's a heck of a start.
That's good. And one more question to Lieutenant Dingy. We have our wonderful Cops and Kids program here in the community, and I'm just curious of thinking how much time is spent, time in education is focused on opiates and the very substance abuse, whether it's alcohol or other substances. So how much time do we focus on that within that 6-week program or so in the summer?
Well, it is a 6-week program. I have different detectives come in and teach different classes. So the way the structure is set up in the program, we usually have 2 blocks of academics, which that includes proactive policing and certain classes in there. So I would say 2 hours of that block, of that 6-hour block, is dedicated to academics. So that time we would bring people in to educate them on those issues, those different issues. And of course we hit the hot topics.
Right.
Like maybe this summer this is a real hot topic. We'll focus strongly on that. And also I would just like to add to a previous question, police, there's a change in police culture when we're training these guys. About a year ago, the past chief, Chief Charette, approached us about Narcan use. And I just want to mention this for our guys because a lot of police chiefs were having trouble trying to initiate the Narcan program within their police departments. It went into the bargaining units, etc. Some unions wanted more money. We approached our union, our guys, and they were willingly wanted to do it right away. We initiated the program, and we thought we were being proactive. We initiated the program. We've obviously saved lives already. And that was us being proactive. Now the next step is, yeah, we arrive on scene, we save their life, but are we just saving their life till the next high? So now we have to, move on. We're proactive, getting the program involved in Narcan. We got an officers involved, and now we're trying to get this involved as well.
And if I can, a deputy reminded me of something I should have mentioned. A lot of departments don't have the, we've got a very good union. We've got our people really care. Our association, they could have fought this. I had heard from other chiefs in the state that, oh, it's a collective bargaining issue, it's a change in working conditions. And technically it is, and they could have grieved it and they could have dragged it on forever, but they stepped up. The men and women that work for this town, I mean, we are very lucky to have them. There was no argument, there were no games, there was no spent money on attorney's fees and going back and forth to Boston for weeks at a time. They want to do this job. They want to help the people in the community, and I respect every man and woman that works for us. And I'm proud to work with them because they don't argue about little things. They know that this is good for the community, so they did it without any questions. And they bought into it right away. So I respect them for that. I know the union president's here, and thanks for all your efforts.
Thank you very much, and thank you for all that you're doing for the community, all of you. It's wonderful to hear what you're telling us, especially. We don't often get as much feedback, so it's great, and the public needs to know. Thanks.
Any more questions? Chief Woodson, could you get the Webster Police Chief and introduce him to us, please?
Absolutely. Chief Bent, I'm sure you didn't think that you were going to be speaking tonight, but can you just come up to the podium? Chief Tim Bent from Webster PD. He's going to be mad at me for this, but I'll blame the counselor.
Well, blame it on me. He's the police chief of Webster, right?
Yes, he is, sir.
Good evening. I just have to echo what Chief Woodson was saying. Our communities are very similar, Webster and Southbridge, as you know. Our statistics are alarmingly similar as well. When he was talking about the overdoses that you've experienced here in Southbridge, we're doing the same in Webster. And much like Southbridge, we are looking into the Gloucester program as well. So, this is why I wanted to attend tonight. I know that Harrington Hospital is here as well. We've had some dialogue with them as well, and this is why I felt it was important that I attend this evening as well to just see what Southbridge is doing and again, working together with my fellow chiefs and doing something that, again, is very important for both of our communities. Again, everything I've heard here this evening is exactly what we've been experiencing and we've been trying to find the solution to. So, I commend the board here and the committee and exactly what you're doing, and I can only hope that Webster is going to follow suit as well.
We appreciate you coming here tonight. I personally do too. Was there any questions? Would you like to say anything?
I'm not going to put him on the spot.
No. I really appreciate you coming tonight because it shows that we can work together. But we might beat you in Thanksgiving.
I think we can guarantee that.
Thank you.
Thank you so much for coming.
Thank you very much.
Thank you, gentlemen.
All right, we're going to move on. Next up is Harrington Hospital, and Councilor Clements will introduce the Harrington Hospital representatives and will moderate this portion of the program. Councilor Clements?
Thank you, Councilor Beckier. I just want to start with, we are very fortunate in this community to have Harrington Memorial Hospital. It was founded in 1931 as a nonprofit, founded by the people in this community who all donated, whether it was $1 or thousands of dollars. It's governed by a volunteer board of directors, and it currently serves Webster, Dudley, Sturbridge, Charlton, East Brookfield, Brimfield, and soon Oxford, or so. Spencer's in there too, yes, sorry about that. And they just have their recent opening of the urgent care facility in Charlton, so that again, they can better serve the community. So we are very, very fortunate to have them here, continuing and being successful. Tonight, we're privileged to have a couple of people to come and speak on this subject. The first is Greg Muirhedge. He's got his MSW and is the Assistant Vice President of Behavioral Health and Director of Recovery Services for Harrington Hospital. He has worked in the field of substance abuse and mental health for 25 years and has developed outreach programs for the federal government of Canada as a consultant to the Commissioner of Mental Health and Substance Abuse for the state of Connecticut, as a research scientist and director of urban outreach for addictions at Yale University, and as a professor at Smith College and Bay Path College in Longmeadow. He has been actively involved in the development of new services and drug courts to address the problems of addiction in Central Mass. He is assisted this evening by Dr. Richard Listrud, an MD at Harrington, who is a board-certified psychiatrist with a focus on substance abusers, and he's able to offer Suboxone. I believe I'm saying that correctly. And Greg can explain that further, I'm told, in his presentation. But thank you for being here this evening, and we are excited to hear what Harrington can do for us and the many that need their help. So thank you.
Thanks. Thanks so much for the invitation. It's a great forum and privilege to be here. Do want to start out by just acknowledging the police, the DA, the trial courts, the sheriff's office, the probation, and the EMS, because the fact is, I think in medical treatment, we couldn't do what we do as well if everybody else out there wasn't doing what they do, and it's very difficult work. And fortunately, we have good relationships with them all, and I think that's one of the unique things about this area is it's a fairly integrated system of care. So I know it's late, so let me start with the good news, because there really is good news, and that is that we're treating twice as many people as we treated when I came here 3 years ago as far as substance abuse, and our rate of overdoses has declined. And that's for people in treatment, and that's a great thing. Now, the problem is that more people are using drugs, and there are more people out there, and so overdoses continue. But for the people that were able to engage in treatment, that's declined. And this issue has devastated I don't know a community that's not been devastated by this issue. I mean, the truth is that heroin is no longer, opiates in general, heroin specifically is no longer the end of the line. Heroin is the first choice in a lot of ways. I met a 12-year-old girl. She was there well-dressed with her Hello Kitty lunchbox and her parents, and she was using 5 bags a day of heroin. And I asked where the most dangerous place for her was as far as risk for using, and she said, as soon as I open the front door to my school. I think pretending that it's anything different than it is now, which is that it's cheaper than it's ever been, it's purer than it's ever been, it's more ubiquitous than it's ever been, is the fact. And it's a disease, and it's a disease that requires medical treatment. And so our belief is if the drug is going to be everywhere, then we need to make treatment accessible. And if the drug is powerful, then we need to make treatment effective. And if the disease is chronic, then we need to have a continuum of care that doesn't end. I mean, it's a lifelong disease, and so treatment should not end. And we try to have a continuum of care that continues to work with people over time, no matter what. And I think we've made great strides in that in the last few years. We've expanded the number of clinics that we have. We've expanded the intensity of our outpatient. We've expanded the range of outpatient treatment. The outpatient staff have practically doubled in the last 2 years in terms of substance abuse. We have the most intensive medication-assisted treatment program in the state, which Dr. Listrud is the medical director for, which is a Suboxone-assisted treatment. It requires that everybody begin with minimally 2 weeks of intensive daily treatment, and then have individual counseling and group counseling and frequent visits with a psychiatrist for as long as they're on the medication. So there are places where you can go and you can get a month's prescription and you can come back another month later. We believe that medication, just doesn't work without the combined treatment. We utilize a toxicology lab that is probably the best in the business. It can detect drugs definitively 4 days back. So there is no false negatives, there are no false positives. We can tell basically what people have been using up to 4 days back, depending on the drug. We just started on Monday the first intensive outpatient program for substance abuse, and we've never had that in this area. People have always had to go to Worcester, and it was a problem because when people went to Worcester, they often didn't come back, or we lost them somewhere along the way. And so this has been great. It's a daily structured program that works with people with substance abuse and duly diagnosed mental health and addictions, and just started Monday, and really I think is promising as part of the integrated care. We received a grant, the CHART grant, that has also allowed us to really integrate clinicians into every aspect. So we now have behavioral health clinicians in the emergency room, in the medical surgical inpatient, in the psychiatric inpatient, and in primary care offices. And those people are there to look for people with behavioral health disorders, and have seen at least 50% of the people they've seen have had substance abuse disorders, and are able to screen, not only screen and assess them, but with this grant we also have patient navigators who are able to follow them and link them to treatment. So this has been a great thing, because the truth is that I wish everybody walked through my front door and just said, I'm ready for treatment, but it clearly doesn't happen that way. People end up in primary care, they end up in the ER, they end up in med surg, they end up all over the place. And so for the first time, we're really able to identify and assess those people and link them to treatment. About 16 months ago, Harrington sat down with Judge Bebo and Nilsa Silvestri, who's the chief probation in Dudley, and said, we can't do this on our own anymore. Medical treatment is failing, the trial court's failing, probation's failing, and people are dying. And we decided that we would come together without funding, and we're the only drug court, I think, in the state that doesn't have funding, and that we came together without funding and created a drug court that I think, in my mind, the Center of Excellence at UMass is actually doing a study on our drug court now, because we graduated in 1 year people who were never involved in treatment, were all opiate dependent, most didn't have jobs, most had multiple violations and incarcerations. We graduated 93% after 1 year. And that was a great success. And I think it showed that this is a behavioral health disorder in the sense that it affects the behavior, substance abuse affects the behavior, and therefore it touches criminal justice, and it touches hospitals, and it touches probation, and it touches all those places. And without working in an integrated model, it just doesn't work. It falls apart. And we've developed a great model. We're trying to expand that to East Brookfield and actually going to Uxbridge on Friday so that it's really county-wide. So no matter where you get arrested or what happens, that you can have the same system of treatment and care. It is very intensive probation, but it's very intensive treatment. And it's worked really well. It's provided a structure, and we really focused young adults, 18 to 27 years old. So that was sort of our target population. I thought we were kind of crazy to begin with, because I would have been surprised if one had graduated at the end, and I really honestly couldn't believe that as many people did as well, and I think it really was because of the clinicians at work and the probation officers at work. Just for a couple other things, the survey that I did after 6 months in the drug court of the drug court participants showed that 40% had DCF involvement when they started, 11% it declined to 11% after 6 months. Employment increased by 35%, and at the end of the year, no one had picked up a new felony charge, and only 6% had picked up a new misdemeanor. So, one of the things we know about recovery is that all kinds of other things get better. Housing gets better, jobs get better, involvement with DCF gets better, involvement with the criminal justice system gets better, and we watch that happen to these young adults. I'll let Dr. Listerud talk more about our medication-assisted treatment and about our treatment in general, but I will say that if there is sort of a missing link, it is detoxification for people. Beds are full in Worcester. I don't think, truthfully, I think if we built another 200 beds tomorrow, I pretty sure those would be full tomorrow as well. And you know, I think that we have to come up with, as a town, another answer. And I think we have the resources to do that. And I think working together the way we have with the drug court and looking at, there's a model in Michigan where they're doing ambulatory detox through the emergency room. There's an assessment center where they're holding people. People can come to the assessment center at any point, and they're actually doing things like prescribing Suboxone out of the emergency room. I think that it's a great model. It's worked very effectively. Yale just did a study on it. It's worked really well, and I'm hoping that that can be our next step, because that is the piece that we're missing. You know, we have all the levels of care. What we don't have is the immediate place to put people when they're opiate dependent. Richard?
So I won't get too much into sort of the general intricacies of Suboxone treatment or other treatments. I will offer at this point to speak to any group in the community that would like to know more about excuse me, addiction treatment. But we do offer Suboxone treatment at Harrington Healthcare. This is a disease that is physical, mental, and many would argue spiritual. And so I appreciate the efforts and the comprehensive vision that Greg brings to our clinic and to the participation of the probation department, law enforcement as well, the fire chief, and all those on the front lines. So, you know, it takes a village to raise a child. Well, I think it takes a village to attack a problem of this scope that is taking lives. Our treatment program is comprehensive. Greg emphasized that we have full-time clinicians available because we insist that patients attend individual or group therapy intensively for the first 2 weeks of their treatment in our program, and then continue maintenance weekly thereafter. This includes weekly drug testing once they get to maintenance, and twice weekly while they are in the intensive phase. So we are carefully monitoring individuals and offering support, including adding individual counseling. And I'll just add, it's been striking to me, even though they teach us all about this in medical school, the degree to which once you start taking away the addiction and have people stop abusing alcohol, opioids, cocaine, the degree to which you may see flourishing a mental health problem, panic disorder, depression, other problems that, you know, these are young people who got going in their, God forbid, 12, but 14, 16, 18. These are exactly the times when illnesses like major depression and panic disorder are coming on board. Not to mention histories of trauma that may lead to PTSD, which require concurrent treatment. So as we address the addiction problem, it is not uncommon, and we are well positioned then in my role and as with our clinical staff to address problems of mental health that may emerge and are essential, because essentially in those cases, many people are doing what they call self-medicating. They're trying to get help for their problem, but they're just using a drug that's not going to work and ultimately lead to its own sphere of problems. So we offer other forms of treatment as well. Many people have heard about, I just heard a story on NPR as I drove in today about Vivitrol. It's an injectable form of a medication that can block the body's response to opioids. It is an effective treatment when can be maintained, because it's a month-long injection, stays in the system, and blocks the effect. If a person were to have a slip on opiates, they would not feel the high of being on opiates. So thereby we take away the reinforcer. We take away, if they try using the drug and they don't get high, well, they just realize they gave away $100, $200 to a dealer and they didn't get high. So the hope is that they can stay on treatment. There are also oral forms of naltrexone as well that are the same drug as is in Vivitrol. So I'm very pleased to be here because of Greg's vision and because of the comprehensive nature in which Southbridge and Webster approach this problem, and I'm open to any questions that anyone might have. Thank you.
Mr. Ron?
First of all, I want to thank you for being such a great partner to the town. I had an opportunity to tour your facility with Ed. We went around and I was really interested in one particular program you had that he had showed me. And it's sort of, I guess it's some type of diversion at the emergency room where somebody comes in with a drug or alcohol problem. You have a way of kind of taking them out of that to a private room with some nurses and stuff. Tell us a little bit about that program. And to follow up with that, I've been in hospital situations on Friday and Saturday nights where there's all kinds of drug addicts. They have no place else to go. They end up being brought by ambulance, and really they're just sitting there for a while to kind of I guess, dry out or whatever you want to call it. Tell me about how you deal with those patients and how we can get them out of kind of the emergency service realm and somehow divert them someplace else.
So I'll let Greg comment extensively on this, but this is exactly what the CHART grant is meant to address. And it's not by accident that people are showing up on Friday nights, because all the primary care doctors' offices are closed and any other doctor who might be prescribing opiates, and the person is out of opiates now. So that puts the ER physician and someone in a bind because he or she cannot corroborate, when was their last prescription, et cetera, even though we do have a good a prescription monitoring program which we are accessing as physicians in that position. But this is exactly what the CHART grant is meant to address in the Navigators. So Greg, if you want to comment on the Navigators.
So it's a great program. That's sort of what I had mentioned earlier, which is we have now, a designated full-time clinician in the emergency room, as well as the backup of psychiatric emergency services that are there 24 hours a day, 7 days a week. Specifically to look for people who may come in, complaining about back pain, but now it's been every 3 days they've been complaining about back pain, looking for something, and to be able to take them aside, do a screening. And the great thing about it is we also have the resources to have a navigator who, in the past people would say you need to go to a drug center, go get treatment. And I think we're able to now sit with people, do a full assessment, have a navigator, meet them the next morning, bring them to the appointment. We have the appointment ready to go, and we're seeing, instead of people falling through the cracks, which usually happens after the emergency room, people get into treatment.
It seemed to me as I was looking at that program that frankly, there's two huge benefits, at least I saw to it. One is you're diverting people to a program where they really need it versus the normal services that an emergency room provides. That's one. Two, it's probably, I would think, extremely cost effective because now you're not taking high-priced doctors, so to speak, or taking care of medical care, utilizing their time. You're providing that time to patients who have real medical emergencies, and you're bringing it to nurses and clinical people who may not need that doctor's training that are lower priced but can provide better quality services in more time. Is that true?
That's absolutely true, and I think it's a push from everywhere is to reduce that utilization of those acute services, and that's why we developed the intensive outpatient program and trying to divert from the emergency room, because also, the emergency room, you're not getting that full assessment. People, it's sort of, the doctors are trying to decide, do I need to treat this, or is this, something that needs to go over there, and so the substance abuse tends never to get treated. People either get the prescription they're looking for, or they're told sort of leave, and because the doctors are dealing with other things. So I think it's a great program, and you're right, it also reduces cost. The cost that they came up with recently for the average overdose, so that includes hospital stay, is $36,000. And so that's not a cheap thing. So anything we can do in the community, obviously, to.
So my last question to that goes: are you unique? Because I had never saw that before in hospitals that I've dealt with. Are many hospitals in Massachusetts utilizing that kind of program, or are you very unique in this respect?
So, I think Massachusetts is unique in developing this vision through the Health Policy Commission and actually giving this grant to hospitals like Harrington. And Harrington got a very large award. And in fact, next year we're building specifically a inpatient hospital for people with dual diagnosis, because there are very few. If you ever try to get somebody into inpatient who have both substance abuse and mental health, you're lucky if you can find a bed. So we're going to be building that on our Hubbard campus, Webster campus next year, as well as a partial hospital program. The Health Policy Commission gave out 24 awards. So now there's 24 hospitals across the state who are doing this very thing, who are really looking to divert from acute need to utilize acute care and to get into appropriate types of treatment like substance abuse outpatient.
Terrific, thank you.
You're welcome.
Other questions?
Just a quick question, and we may cover this with the next speaker as well. I'm just wondering how the methadone fits into this, and should we be moving away from methadone into Vivitrol and some of these other treatments? I'm just kind of concerned. We've been with methadone for a very long time, and I'm just wondering if we're trying to advance past something like that.
I'll let Dr. Listerwood sort of speak better to that. I guess my feeling is, I'm willing to throw anything at the disease that I can to try to get somebody, stabilized and in recovery. I guess my feeling always with any kind of a medication-assisted treatment, and just to talk more generally, is I don't find that it's generally helpful unless you also have the treatment to go along with it. And so my concern about anyone prescribing Suboxone, anyone prescribing methadone is, if you just have to show up and get your methadone and then, maybe you have a group 3 weeks later, that's not great treatment. I don't think people get better and stay better over the long run. I think that this kind of intensive treatment is necessary, whether it's Suboxone, Vivitrol, whatever. I don't think medication alone, I think it works for a while, but I think ultimately then people sort of fall off. But I'll let Dr. Lister.
I'll just comment. I agree largely with Greg, and I'll just say, but the statistics about methadone are impressive. So the degree to which it helps people stay out of jail, the degree to which it helps pregnant women who are opioid addicted get through their pregnancy and deliver healthy babies cannot be argued with. So it has a powerful place in our sort of arsenal of treatments. But I'd concur with Greg, and I would just share that what's exciting about this program compared to other places I have worked before is we hold people to accountability. And so ours is an abstinence-focused program. It is unacceptable in our program, unlike many others, including some I've worked in, for a person to walk in and consistently show up positive for marijuana. If you show up like that at our clinic, we will be speaking to you, we'll be offering additional services, and at some point, if that doesn't change, then we will be referring you to a more intensive treatment, because what we're doing for you is not enough. So ours is an abstinence-focused treatment. We're not based in any specific, what's called a cognitive behavioral treatment or a 12-step AA or NA philosophy, but we are abstinence-based and encouraging people to access those other forms of treatment, offering those other forms of treatment in-house. So, I guess to answer specifically your question, agree with Greg. Methadone has its place. It has powerful statistics that argue in favor of it. But the focus, at least for the program that we run, I don't prescribe methadone in my practice. But the focus that we have made our goal is abstinence and supporting persons who are abstinent.
Thank you.
Just a couple of things. One, thank you for touching on the new facility that you're working on, because that was one of my questions as to whether you could expand on the plans for the new behavioral health and substance facility. So I appreciate you letting the public know what's going on, because that's a wonderful program and a wonderful, I can't even think, I think it's going to provide great services for this community and beyond. So looking forward to the opening of that. I had been told we were 1 to 2 overdoses daily in the ER. Statistically, I was told that we're seeing 1 to 2 overdoses in the ER. I mean, obviously that probably is a realm of many things, and obviously they don't all end in death or all, because certainly the statistics locally don't have that. We hear now you have some options, obviously, when people come in, but how difficult really is it at this point? I mean, the governor's giving us more money. Hopefully, things are going to go well there, and you'll have more funding to provide more services. But the protocol on these ODs and how difficult it is to steer them into the right resources, to get access to the right resources if they just walk in, show up, and, hey, something's wrong, or they get brought in by ambulance, or obviously, the ones that are coming in and can be managed in the other facility, in the nearby facility versus the ER is one thing. But when you actually get somebody who needs the medical care along with then the next process, I know a lot of times it's very difficult, as you said, to get a bed, to get this, we're going to have a 72-hour option, but if there's nowhere to put them. Right. So I guess I'm looking to see what are we doing, and is that true? Is that number what we're really looking at locally in terms of the overdoses coming into the ER?
I haven't seen the specific statistics for Harrington in this area, but,
it
wouldn't surprise me.
And I think that, that number has only climbed. Like I said earlier, I think the great thing is that those aren't people who are presently in treatment, most of them. And so that's the great news, is that when people are getting into treatment, the overdoses are actually getting, so our overdose rate has actually dropped 31% over the last 2.5 years for people in treatment. And we're getting more people into treatment. But your question really is, what happens when you get to the ER? And so that's part of the CHART grant, which is that, clinicians, navigators are there, because, my feeling is, especially with, a disease that is, a chronic relapsing condition, people are not, saying to somebody, show up at this place tomorrow, you know, you got 12 hours between today and tomorrow. So, you know, that's a lot of time for somebody. And so without those things like navigators, the other thing is that, you know, we try to do is we try to make, you know, in substance abuse, the window often is very, very small when people are ready for treatment or people feel like, okay, I've had enough. And it can close very quickly. And so, you know, if somebody's ready to go on Suboxone, we try to get people in within 3 days. And that's almost a record, I think, in the state. I mean, usually you're waiting and you're going through assessments. And I mean, from the time you walk in the door the first time to the time of induction, I mean, we've done it in 3 days or, you know, almost less in some ways. And I think that's important. So I think being able to, you know, to have the resources so that we can continue to get people in, because it's fine, again, to refer people from the emergency room, but if it's, you know, come here in 3 weeks, that's, you know, that's not going to work. But I think the CHART grant has given us that. And again, you know, what we talked to Chief Bent about and other people about, starting ambulatory detox within the emergency room and trying to develop some sort of assessment center where we can actually hold people, start them on Suboxone, make that link, have a navigator follow them to the treatment center. And once they get a few days under their belt, then things can change.
And I'm glad that you brought up the correlation between, you know, behavioral health in general, you know, mental health issues and such, and substance abuse, because a lot of times people just don't realize which one caused the other, or that they're both so closely intertwined. And again, with behavioral health, again, from personal experience, you end up with, a lot of times you can't get the referrals, you can't get into a service. It takes months to get an appointment, for somebody to get you an appointment to maybe get you that depression treatment. In the meantime, perhaps you've branched out and looked for some other way to treat yourself. And so, again, applauding our local hospital for being able, for realizing that and stepping up with the behavioral health end of things, and again, just trying to manage our area. So I think the effort is expanded, you know, with so many other hospitals out in Massachusetts and beyond, and it needs to be a collaborative effort. So thank you for your time here this evening. Any other questions? Oh, sorry, didn't look this way. Yes.
Actually, I did have a couple. One is, you talked about Suboxone and methadone a little bit. How do you prevent that? Could you describe a little about how that works? Because how do you prevent that from becoming simply a replacement addiction?
Something that, I'm sorry, I missed the last
How do you prevent the Suboxone or the methadone from becoming essentially a replacement addiction? How does it work?
Okay, so patients sometimes come in and ask me this very question, okay? Am I addicted to Suboxone now, doc? And has that really helped me or not? And I would suggest that addiction is a set of behaviors that is not helping you. Okay? It's a set of sometimes legal problems. I'm breaking into cars to get money so I can support my addiction. And so there is a difference between the body becoming physiologically accustomed to a certain medication, and there are many such medications, not just medications for addiction, but I would suggest antidepressants and other blood pressure medications and so forth, where you are ill-advised to stop them abruptly.
Right.
Okay? There will be problems if you stop them abruptly. So just as in these cases, methadone and Suboxone cannot be stopped abruptly, or a person will feel exactly the same withdrawal side effects that they would have with an opiate. Does that mean that they're the same as an opiate and we're just substituting one for another and it's all just addiction anyway? And I will argue vehemently no. Because the problems that bring people to our doors are, I'm now involved with DCF, I've now gotten a DUI, or I've just gotten out of I'm on probation and I've decided to do drug court now. These are people experiencing significant problems. I've been cut off from my family. I'm now homeless. So these are the behaviors I will suggest that are connected to one's addiction. Okay. So the point of treatment is to try to get your life back, and that is our aim, and I'm certain it's the aim of Spectrum, who provides methadone across the hall from us. Okay. The goal is to help you get your life back and get these problems, help you to take care of your problems. So does the body become, in a sense, accustomed to the medications methadone and Suboxone? Yes, it does. But the goals of treatment, at least I can say under our roof, are that, and I believe so for methadone too, are that we're helping you in the meantime. We're not just stopping there. And so when you're in the maintenance program, if you're having relationship problems, well, we will talk to you about your relationship problems. If you're having money problems, we'll be helping. And Greg's data about people getting jobs while still in drug court is quite impressive for this reason. So these are people getting their lives back together and living more meaningful lives that they want to lead. I tell all my patients that my job is to help you get back in the driver's seat and not let your addiction run your life for you. So sometimes clients do come in and say, Doc, am I just addicted to Suboxone, whereas before I was addicted to Percocets? And I'll say, well, you tell me, when you came to us in treatment, these were the things that you described weren't going well in your life. And now tell me about your life. And I'll tell you, they'll say, well, my relationships are better, my money, my bank account is better, I've got a job now, I've got my kids back in my life. These seem like reasonable goals. And yes, if a person decides they want to come off of either methadone or Suboxone, we have tapering protocols. The difficulty is for many individuals, and you'll see it all over the internet, some people will say, oh my gosh, getting off Suboxone was so much harder than dropping heroin. And I'll just say, well, I'm not sure it was harder. It was just you might have assumed it was going to be easier. Because I'll tell you, our clients are not acting high on Suboxone because they can't get high on Suboxone. It's physiologically constructed in such a way that you don't get high off Suboxone. There is a separate question as to why dealers offer Suboxone. I'm convinced why dealers offer Suboxone, they do, and dealers offer Suboxone to keep people hooked. And at some point, they don't have enough Suboxone, and sure, well, here's a $5 bag of heroin, though. And so that's what they're going to offer to the individual who's in bad withdrawal at that point. So our goal is to sustain them on Suboxone, help them rebuild their lives, and then if they decide they want to talk about tapering, then my job as a doctor is to inform them of risks and benefits and talk about a reasonable strategy and also inform them, because the body gets accustomed to this is going to take some time. You can't just stop it. Our usual goals are something like a 10 to 15% dose reduction over about every 2 months. But some powerful research has come out of UMass about nicotine addiction, and they say that people with 2 packs a day of cigarettes get down to about 5 cigarettes, and then many will say when they finally get off those 5 cigarettes, I had only done half the job when I went from 2 packs a day down to 5 cigarettes. The other half of the job, the other 50% of kicking cigarettes was finishing those last 5 cigarettes. That seems to be a physiologic phenomenon. It's not merely psychological. There's good data suggesting and supporting that this is a disease. We're not yet at the point where we can pop someone in a scanner, and I'm interested in hearing the Attorney General DA Attorney, his quote about a drug test to determine a risk of addiction. I'm not aware of any just yet, but they're working towards it. So every bit of disease, genetic underpinnings, different functioning of the brain that we can demonstrate on sophisticated research MRIs, but we're not yet at the point where we can pop someone in a scanner or an MRI and diagnose their problem. But absolutely, we can help people taper off of a medication when it's clinically indicated and makes sense.
Time's up.
Say, Councilor Vecchia, would you like to say something?
No, his time's up.
Okay, I just want to thank Mr. Mirhish and Dr. Listred for being here.
Thank you.
Thank you very much.
Thank you.
Thank you. Our last guests are the people from the Spectrum Health Services, Inc. So they can come up now, Spectrum. And Mark Orris, did I pronounce the name right, Orris?
That's it.
Regional Program Director, has been employed with Spectrum Health Systems for 14 years, overseeing both the Southbridge and Merrick Street outpatient treatment centers. Go ahead, Mr. Orris.
Thank you. I want to thank the town council for inviting us and putting this together. I want to thank Chief Woodson. Earlier he threw me under the bus, and I'm going to throw him under the bus. I was blown away the day that I got the call from him that Chief of Police was actually calling me with the request that he was asking. We actually did get that gentleman into treatment, which was huge. So I wanted to thank him. I think the town is very lucky to have a Chief of Police that's invested like he is. So thank you. We wanted to present tonight, just kind of give you treatment provider's perspective of what we offer at Spectrum Health Systems. So we have kind of a two-part. I'm going to turn it over to Lisa Blanchard. She is the Executive Director of Outpatient Services for Spectrum. She's going to kind of give a company overview, and then I'll talk about the program in Southbridge. So, Lisa.
Let me move this over because I don't know if I can reach those tabs and mess with the AV system. Can everybody hear me okay? All right. Yeah, go ahead. There might be some cool effects here. So Spectrum is a nonprofit organization. We've been around for over 40 years. We've grown significantly. We now have about 1,600 employees. We are in 6 states. We have 130 programs, and we serve 80,000 clients per year. It's a 30% increase in the past year. So here's where all the cool effects come in. So these are all of our outpatient treatment centers in the state of Massachusetts. And of course, you'll see there Southbridge, which has been here since 2009. We offer medication-assisted treatment, outpatient counseling for both addictions and behavioral health. We're licensed both for substance abuse and for mental health. We have programs in Haverhill, Waltham, Framingham, Milford, Southbridge, 2 programs in Worcester, 1 in Pittsfield and North Adams out in the Berkshires, and Saugus and Leominster are our 2 most recent openings. Just to give you an idea, we've had significant census growth. Probably several years ago, I've been with the organization for over 16 years. We probably had about 1,500 clients across our entire outpatient division. If you really totaled all of these numbers, we're certainly much, much higher than that. You'll see that Southbridge is at 342. It's about around 340, 345, depending on the week. And that's been a significant increase over the past couple of years. Again, our newest programs are in Saugus, North Adams, and Leominster. One of the most interesting things that's happened in outpatient, which affects all of our outpatient programs, including Southbridge, is we were awarded a pretty prestigious Attorney General's grant. So it would have been great to thank the Attorney General's office earlier as well, to actually connect inmates out of the state prison system to medication-assisted treatment. It's actually the first program of its kind in the entire country in a state prison system. And so we're using, similar to what Harrington was saying earlier, recovery support navigators to really build those connections, because it's so difficult post-incarceration to connect people to medication-assisted treatment or to services in general. So the Bureau of Substance Abuse Services actually expanded that funding, and so we were able to make that much larger and spread throughout the state. And as part of this, we've been piloting the use of injectable naltrexone, which you've heard a little bit about today, which is Vivitrol, which is, in the first injection is actually given prior to release from incarceration, which is very exciting, and it puts people at a much lower risk of overdose when they leave the prison system. So Spectrum has been the leader in this. We also run the substance abuse programming in the state prison system. We also work with the county jails. We've worked with the Worcester House of Correction and some of the other House of Corrections in the state to do similar programming. In response to the need to the opiate crisis, not only have we opened more programs that offer medication-assisted treatment for methadone, which I'll talk a lot about today, but also increased our capacity for buprenorphine, which is Suboxone, and for naltrexone and Vivitrol. Some of the other exciting programs that we offer are peer recovery support centers, which are peer-run, peer-led, just recovery drop-in centers. And we're fortunate to have them in Worcester, those little things bounce, Marlborough, and our newest one is in Lawrence. I'm going to talk a little bit about our inpatient services, in part because it's a really useful resource. You heard the Chief of Gloucester, Lenny, talk a little bit about how Spectrum has really been a great partner in their initiative, and although they're way up in Gloucester and probably our closest services to them are in Haverhill and Saugus and not directly where they are, they need beds. They need access to inpatient care. And so they put out a call and they said, we need help. And so Spectrum responded. And so really our inpatient division has done quite a bit of work to respond to that call. And he actually quoted to me when I met him here earlier that about the 281 individuals that they've entered into treatment as part of the Gloucester Initiative, about 100 of those were placed in Spectrum programs, which is something that we're very proud of as an organization. So this shows our outpatient locations in Westboro and Weymouth. And a little bit of a description. So our Westboro program is a residential, which is now actually just increased to 100 beds. Our detox program has 45 beds. Our TSS, which is a transitional program, usually post-detox or for homeless individuals, has 38 beds. And we have a young adult program with 18 beds. We did also open, within this past year, a program called the New England Recovery Center, which has 38 beds that can allow both for detox and for residential after that. In Weymouth, we have both CSS beds, which is clinical stabilization services. We have a residential, Project Turnabout, and we just recently added detox beds. If anybody's heard a lot about access to inpatient, when they closed all the programs out in Boston on Long Island, that left a lot of people without treatment in the state in general and placed throughout the state. And so we did our best to respond to that call. And we also have 2 drug-free houses in Worcester. So not a surprise to this group. We've been talking about it all day. A lot of information has come out. The overdose rates in the state continue to climb. Spectrum serves on several task forces to address local overdose prevention, including Worcester, Waltham, Haverhill, and Methuen, and work really closely with all of our local police departments and fire departments. There's some basic data here, which we've probably heard some of these quotes, but this data just came out in October 2015, and although it takes a while for the kind of formal data to really come through, it really shows that the unintentional opiate-related overdose deaths, most often heroin, have really increased significantly since the year 2000. It's a 251% increase, which is really unbelievable. Specifically, Worcester County has steadily increased as well, and so 2013 and 2014 saw an increase of overdose deaths by at least 50% from the previous 2 years. So I'm going to turn it over to Mark to talk a little bit about your specific community in the Southbridge Opiate Treatment Program.
So we opened the doors of our outpatient treatment facility here in Southbridge in 2009. We had a census of 52 clients. Those clients had transferred from our Lincoln Street site. Currently, today, our census is 344 clients. In 3 years' time, our census has grown by almost 60%. 57% of the 344 are from the town of Southbridge. The average age of clients seeking treatment today is 18 to 30 years old. You can see we're pretty even at the program, the male and female, 185 male clients. We have 159 female clients. We broke down the age range so you could see. We offer a family engagement meeting on the last Wednesday of every month at 5 o'clock at our site. Everyone is welcome to come. We talk about methadone, we talk about the treatment philosophy of what we want at our clinic. We are in connection with law enforcement here in Southbridge and outside of Southbridge, and we're really connected with the Family Health Center. They've been a huge advocate for our clients that haven't been able to find a doctor and a PCP. We've referred them to the Family Health Center, and they've been really great. We have a same-day walk-in admission, we call it, on Tuesdays starting at 6 a.m. If you're seeking treatment, you can walk into our facility here at 176 Main Street. All admissions, there's steps to be completed. You'll see the doctor, you'll have a clinical intake, you'll be assigned to group, you'll be assigned to your clinician, and you'll be able to receive your medication that day.
So I'm going to take over, and there were a lot of questions about kind of the differences in medication and what is methadone treatment, and there's a lot of misinformation out there. There's a lot of rumors, there's a lot of innuendos, and quite often, probably our patients who are struggling the most often can be the face of treatment, and it's not always the most accurate. So we always find it really helpful when talking to communities to really kind of talk about what is methadone treatment and what isn't it. And so, methadone treatment is probably the most highly regulated service out there. The regulations for methadone treatment in our state regulations for the Department of Public Health are probably about 5 times longer than any other level of care. It's been around for a very long time, and you'll see some statistics that were obviously referenced earlier as well. But some of the real benefits are that it's observed medication dispensing. So there are a lot of clients who can't manage a prescription, can't manage self-administration of medication, can't handle a lot of that. And so clients actually receive their medication in front of a nurse, taken, observed to be sure that they actually ingested that medication, observed to be sure that they're not impaired before we give them that medication. Breathalyzers are often done. Obviously, there's a fair amount of drug screening, and we monitor for other drug use, alcohol use, social problems, and mandated behavioral health counseling. We have a very structured program. In fact, probably more structured than any other methadone treatment program that I'm aware of in the state, and I do a fair amount of quality improvement coaching in the state. We have a very structured curriculum that everybody's in weekly group pretty much for the duration of their treatment, and they're all in individual counseling. And that may vary. It could be weekly if you're struggling or new. It could be every other week, but no more than a minimum monthly for individual counseling. If clients are struggling in our program and continuing to test positive, again, very similarly, you cannot still continue to use opiates or cocaine or benzodiazepines or other drugs of abuse and still be on the program without any consequence. We're going to do whatever we can to intensify your level of care. We actually have an intensive treatment track that if you continue to test positive, you're actually stepped up a level of care and you're required to go to 2 groups per week plus weekly individual counseling. And if that still doesn't work, that's a 12-week program, then we are going to refer you to a higher level of care. You're really going to need to be referred to, inpatient, residential, something that can work for you. So kind of what is methadone? It is a synthetic opioid agonist. It does have a slow onset of action, so it lasts 12 to 24 hours. So that's why clients can come in once a day and receive their medication versus short-acting opioids that you might have to take every 4 to 6 hours. It's dosed for addiction only in licensed addiction treatment centers. So you actually have to have a license to provide methadone treatment in order to do that. Physicians can't prescribe methadone for addiction unless it's part of those very strict state and federal regulations. It can be both for detox and for maintenance. So methadone dosing, low doses will leave withdrawal, so you don't feel that constant cycle of withdrawal. Moderate doses reduce craving. Higher doses block opioid drug effects, and an average effective dose is between 80 and 120 milligrams. So why opioid maintenance? Why be here for a long period of time? Some clients come in on a detox protocol. That could be a 6-month detox, especially if your use history isn't very long. You haven't had multiple treatment episodes. You're more likely to be admitted on a 6-month detox to stabilize and come down within 6 months. But many people, need to be in treatment for much longer to really achieve sustained recovery, much like diabetes or other kind of chronic diseases. So 80 to 90% relapse without using methadone or other medication-assisted treatment. It increases treatment retention, so it kind of keeps people engaged. You're coming in every day, you've got a structure, you come in, receive your medication, we do worker hours so that you can leave and then go take care of your families, go to work, become part of society again. 80% see decreases in drug use and crime, and 70% decrease on all-cause death rates. So there have been some studies about it, and this, it was replicated in 2003, and so I know that injectable naltrexone is somewhat of a newer medication, but methadone's been tested for a very long time. It's probably the most tested treatment for medication-assisted treatment for addiction, and elimination or significant reduction in illicit opiate use. Methadone sees 50 to 80% positive outcomes. Buprenorphine certainly has some great outcomes as well. Naltrexone, that's really going to only be looking at oral naltrexone, and that's relying on somebody taking a pill, and so we're kind of waiting on some more studies on how injectable naltrexone fares. Okay. So this is kind of the slide that everybody really needs to see, and that's dispelling the methadone myths. It does not make patients high. If dosed appropriately, if clients are impaired after receiving their medication, they have likely added something else on top of that. And so we do a lot of post-dose monitoring to check for that. Peak dose is, between 3 and 4 hours, where you're going to see the full effect of the methadone, but then the full half-life will go 12 to 24 hours. And if folks are taking benzodiazepines or other things that can work in concert with methadone, then we're going to monitor you for 3 hours after your first dose of medication to be sure that you're safe. Methadone patients are not all drugged up and unproductive. We strongly encourage and work with individual treatment plans and continuing care plans to get people back to work, volunteering, taking care of their kids, getting back out there into the program. One of the biggest things that we really stress is our treatment, medication is just a tool. The counseling and the work that we do is really what addiction treatment is about. The medication is just going to protect you from withdrawal and keep you engaged. The rest of the work is in the behavioral treatments. And we really strongly teach pro-social behaviors and really kind of being part of the community. In fact, we ask all clients in all of our outpatient programs to sign good neighbor agreements, where we're saying it's on you to be a good neighbor, to put a good face to addiction treatment. And so they actually sign a specific agreement for their specific program with a specific address on no loitering, no hanging out near other businesses, not impacting the community negatively, not even driving inappropriately. And we do hold clients very strongly to that. Patients are not seeking methadone out for fun. It does not give you that up and down, that rush. It has that long half-life, so it's not really giving people a lot of that kind of up and down high, if that's what they're looking for. Patients are not trapped in treatment. You can walk out at any time. It's going to be uncomfortable if you're on 80 milligrams and you walk out, but you can do it. It's not okay, like I mentioned earlier, to continue to use drugs, opiates or otherwise, and still be in treatment. It's not a substitute addiction. Very similarly to how we heard earlier, it does create physical dependence, but not the associated behaviors. And methadone on the streets that's being abused is rarely from methadone programs. Because it's observed dispensing and we're very restrictive with take-home medication, methadone on the streets is often prescribed for pain in pain programs, and that's what you'll kind of see on the highlights of overdose deaths. Some more fancy graphics, try to keep us up at this end of the night. And that's really Spectrum's motto, what we do is important, how we do it makes all the difference. And we're really happy to take questions from anyone.
Town manager.
I got to say, in terms of presentations tonight, this is the most difficult one because this is reality, what we're looking at. I think of the war on drugs, and I don't think we're losing. I think we're getting slaughtered looking at the numbers that are increasing in terms of treatment, how many people are coming for treatment, and the rise of level of deaths here. So, I guess it puzzles me because it's becoming so much part of the culture these days that even young people are accepting this as a cultural thing, that it's just okay. Yet we're seeing so many people's lives destroyed by it. I'm having a hard time understanding why it's part of the culture when everybody sees what it's doing, How do you deal with that culture issue? I mean, the people that are coming to your treatment center, it's part of their lives, it's part of their culture. How do you overcome that cultural thing, that it's okay, that somehow this is a good thing? It seems to me our attitudes are lost here, and I'm not sure how you get people away from the culture.
That treatment's okay to be in long-term treatment, or that the drug culture is okay?
Well, it seems to me it's not the treatment I'm talking about, but it's the culture itself. It seems acceptable now to do heroin or cocaine, it more so than when I was a kid. Now it seems like, and I've asked high school students for many years, what percentage of your friends or people you know have tried heroin or cocaine? Back in my day, that would be less than 5% or 1%. Today, I'll tell you, every kid I ask, they'll say it, and I don't know if it's true, but it seems pretty everybody seems to agree that it's like 50% have tried heroin or cocaine. It's a different world than most of us adults can really grasp. Why is it so acceptable, and how do we break that acceptance that this is okay to try heroin or cocaine? And how do you get people to stop that once they're in that culture?
I think you're absolutely right. I mean, I think the trend to younger and younger clients, I mean, if you look at the statistics that we presented, probably in outpatient and overall, but especially in central Massachusetts, we have probably one of the highest rates of folks, that are 18 to 24-year-olds. In fact, we have we actually are in the process of developing a very specific separate track for those young folks to really kind of deter that. We don't want those 18 to 24-year-olds to turn into our 40, 50-year-olds who might still be on the program. And that's something that's really important to us, and to try to, engage them in recovery earlier. And so we have a young adult residential. We actually our director of clinical was just trained on the ACRA model, which is an adolescent and has been used in the state for young adults on kind of a really focused psychosocial approach that's a little bit different than working with adults, and really looking to do kind of separate tracks to really do, I think what you're trying to get at is change that culture. Kind of stop that, as soon as we can, so that we're not seeing this kind of repetitive cycle 10 years later, 20 years later.
So is the answer that, and I think of it this way, I guess, in my history of watching this whole drug culture and having had a brother that actually died from an overdose, it seems to me the quicker you can get to somebody when they're just beginning drug use, the better chance you have of saving them. The longer you cover for them, the longer you protect them, the longer you not admit that there's a problem, the more likelihood that they're going to die. That's what I see. Is that accurate? We need to get there immediately at the time somebody first starts getting involved in this culture, than waiting and trying to support them by protecting them. It seems to me we make a mistake in that.
I would absolutely agree. In fact, I think it's a couple-pronged approach. It's educating parents. And so I think Learn to Cope is a wonderful organization. We've done a lot of work and presentations with them, and they really do a lot of work to educate each other about what are the signs that your kid is using. What are the signs that, you can look for? What does paraphernalia look like? Because some parents have no idea. And so the sooner you can stop parents from kind of that enabling process and trying to just protect them and get them into treatment, I think absolutely the better. But it's also through the education system. We've done a lot of work in some school systems to just provide kind of educational forums, whether it be to students, PTO, teachers, to try to catch people much earlier. We'd be happy to do the same for Southbridge, because I do think you're right. I think that the sooner you can catch them, the better. That's why we believe really strongly in open access. So we do walk-in admission. It's made it challenging for us. It's not easy to do walk-in admission it's very complicated to admit to methadone treatment. It's a lot of steps, and it's a long day. But we give people granola bars and water and say, at the end of the day, you'll be on the program. You don't have to think about appointments. You don't have to schedule anything. You just show up, and we'll take care of you.
One of the things that I see, and it angers me dramatically, and I'll tell you what it is that I hear parents, because in our day when we were younger, marijuana was what I would call clean. It was just grown from the ground. It really wasn't mixed with a lot of things. So I hear parents today say that, pot's okay, because in their mind years ago it wasn't so bad. And now we're hearing about states legalizing marijuana and all that stuff, right? And it seems like it's okay. My understanding in dealing with police departments, and please tell me your experience, that the marijuana today that's on the streets today is laced with more other substances and more damaging and stronger than the marijuana that's ever been around. So this misconception that this legalized pot's okay and that means that pot hair is okay, tell me about that, because I think seniors and people of my age need to understand that the world has changed.
Absolutely. What's out there has changed quite a bit. And I think because of the changing culture with acceptance of pot, like you talked about, but there's kind of the wax, the dabs, if anybody's heard about that, it's a little bit more scary. We've actually, had plenty of clients in our outpatient that have reported use of that. If you really look it up, it can cause kind of, much more strong symptoms than kind of what we're used to with, you're not just going to get the munchies. You could, hallucinate on some of these, different kinds of marijuana that are available and all the different ways that they're available. And, they're available in much, easier delivery systems. And it's really has changed quite a bit. And, it can be for many people kind of an entryway. Once you accept that, what are you going to accept next? And it definitely, we've seen that. And really often the pill piece, starting with parents. Well, I would smoke pot, I'd drink, and then occasionally I'd take a pill because, I'm an adolescent, nothing's ever going to happen to me. And then, the repetitive story we hear over and over and over again. So then I did it on the weekends. Then I continued to do it every day. And then I started feeling that withdrawal. And then I couldn't access the pills anymore because my source dried up. And then I had to go to heroin because it's cheaper, it's accessible, and I'm a kid, I'm not working, I don't have any, way to do that. And then they walk into our walk-in admissions, and it's heartbreaking.
Thank you.
Just quickly, you've mentioned something that I was happy to hear about in terms of people being able to kind of come in and being treated that day, because I know there are other agencies, and whether or not yours is one of them in the past, I don't know, but there have been agencies that if somebody comes in and they are sober at that time, have been sober for a few days perhaps, they're basically told, sorry, you can't come in. I know of one individual who going through withdrawal, went in and into a facility in Worcester and was looking for help and was told, if you come back in a half hour with a dirty test, you're all set. What kind of message are we sending when we do that, and how do you handle that sort of a situation?
Drug screening is absolutely only one way to tell that somebody is addicted to opiates. Now, is it true that we have to follow a lot of regulations and be 100% sure that you're addicted to opiates before we give somebody opiates to treat that? Yes, but there's a lot of other ways to do that. And so we actually really kind of look for observable withdrawal. So even if your tox screen is negative, maybe you just came out of detox, maybe you just left jail, maybe you've just been able to put together a few days and you've been white knuckling it and you really are uncomfortable, we're going to be able to see that withdrawal. So we don't give the message that you have to have a positive screen. We actually tell people we need to be sure you're opiate dependent, so please come in acute withdrawal. So we can actually see the withdrawal symptoms, because that is actually going to be much more of an admission criteria for us than a positive tox screen. And positive tox screens aren't always accurate. With fentanyl, we've heard a lot about how scary fentanyl is. That's not part of most programs' typical drug screening. And so, the Bureau of Substance Use Services actually put on an alert, like, please don't not admit people to treatment programs if they're negative for everything, because it could be fentanyl. And we had already been not doing that for quite some time. We're going to use kind of all of their history and information to decide if this is a good treatment option for them. But we did just recently get our lab to include fentanyl in our screens.
Thank you.
That's the last question. Time's up. Thank you very much. I want to thank all the speakers for coming tonight. I also want to thank Town Manager San Angelo and Police Chief Woodson for their help in partnering with me to put this on. I really appreciate the help these two guys gave me. Now, that being said, I'd like to thank the panelists for coming tonight, and I will let the panelists speak if they want to give closing statements. Would you like to give a closing statement?
I think everybody's just about ready to go.
Well, a few people want to give closing statements.
That's
Do you want
okay.
to give it, Denise?
No, just thank you. Thank you for our community and for all that everyone is
Would you like
helping.
to give a closing statement, Sarah?
Sure. The Southbridge Public Schools is very thankful to be here tonight. I know it's late. Thank you for all of the panelists. We are partnering with most of the folks who presented, and we appreciate that effort and the partnering moving forward.
Gus, would you like to give a closing statement?
Honestly, I'm brain fried and I don't know.
Okay. Town Manager?
Thank you, Mr. Chairman. I do want to just speak for a minute here, because when I came into Southbridge, I had an opportunity to meet with each individual counselor to talk about issues that were important to them. In my discussion with Councilor Vecchia, he made this issue his prime issue that was important to him. And quite frankly, I was surprised, because in towns I've worked at, everybody runs away from this problem. And for the first time, a counselor came to me and said, I want to deal with this problem. We can't fix it and come to a solution until such time as we recognize it and bring in experts to talk to us and bring this issue forward to the light of day, and then we can start moving on solutions. So I appreciate Councilman Vecchier's leadership in this issue. I also want to say is myself and Councilor Vecchia and our police chief reached out to the different organizations that came here tonight. Not a single person said no when we invited them here tonight. Nobody argued with us, nobody challenged us, nobody said who's going to be there. They said yes, we'd love to be part of this discussion. From Harrington Hospital to Spectrum to the district attorney's office to Sheriff Lewis to the police chief, the fire chief, the state, the school system, everybody immediately jumped to this issue. And really the only way we can solve this is through that partnership that we put together. So I appreciate that partnership, but I also want to send a message, and I appreciate the people that are here and the people that are home watching us tonight. I want to send a message that while we can all work together and we have a great team of people that care about this community, the real problem and the real solution lies right at your own doorstep. People that are watching this show needs to get involved early, talk to their children, get involved with their family members, try to stop this as quickly as possible, and let people know about the dangers that this substance abuse and these illegal drugs do. So we're trying to help, but again, we need your help, the people that are watching this show. You're the sort of the first line of defense, and we can be there to support you, and there's organizations that are here, but we need your help. And that, with that, Mr. Chairman, I thank you, I thank the members of the council who've stood up to deal with this issue, and it's right back to you, Mr. Chairman.
Thank you very much. The last speaker, closing statement, will be Councilor Moriarty.
Thank you. I wasn't really planning on doing much in this regard, but as the evening wore on, and I thought introspectively a bit more about it, in particular having a younger brother who, knock on wood, is over a year now clean after numerous relapses and instances and so forth. And those who know me know that sometimes I will ramble if I'm not kind of constrained in some way. So I've kind of put this down in some notes, which I don't normally do, but I couldn't agree more with Chief Campanello, Chief Woodson, District Attorney Early, and the other speakers tonight that pointed out addiction is not and ought not to be treated as a crime, but rather it is and must be treated as a chronic illness. We need to be more proactive in treating and combating that illness. Tonight was a great first step to start the conversation, and it is a conversation that is very much so long overdue. 16 months or so, I urged several members of the school committee to look into bringing in Chris Herron and the Project Purple campaign into our middle high school. Many other schools in the area have done that. Many other schools in the state have done that. Many other schools across the country have done that. And it is something that I want to renew here tonight, not just for the school department to strongly consider this, but perhaps through or with in collaboration with Harrington Memorial Hospital, Cops and Kids, the Cultural Council, or any sort of combination thereof. The students, being a guy who's in school with high school kids all the time and have been in a number of different schools, to see some of the kids and how they've responded to that particular program is nothing short of a miracle in terms of their response and their reaction and their dedication to it. Earlier tonight, Chief DeFranzo and Chief Woodson noted that it was only a couple short years ago that we had roughly the same number of overdoses annually that we've had in the last month and a half, if I recall. And this is an alarming trend, to say the least. We cannot afford to simply just see this happening, think about it happening, talk about it happening, complain about it happening. We've done that for far too long, and we do that far too often on far too many issues. We've done that with a stretch of Route 20, known as Dead Man's Curve. For countless years we've been doing that, and countless people in a number of different positions that could have and should have and would have done something about that perhaps have perennially failed to do so, resulting in God knows how many accidents and injuries. And just last week, 2 tragic deaths, another accident there, big accident there today. It took basically a slow news day for the Boston media to come out here to prompt that coverage of this often ignored portion of Massachusetts. And it appears that that push has finally forced some actual movement towards addressing that problem. We can't wait for something so dramatic and so tragic as that for us to move forward in terms of dealing with the opiates. We need to do more than just preach abstinence because it is a failed argument that, statistically speaking, is woefully ineffective. Simply telling kids not to smoke a joint doesn't stop anyone from taking a toke. Telling kids not to drink alcohol has not stopped underage drinking, alcoholism, alcohol poisoning. Telling kids to abstain from having sex hasn't stopped teen pregnancy or the spread of VD. Telling kids to abstain from crushing up Smarties and candies and powders and snorting them hasn't stopped them from giving that a shot either. We need to do far more than that. This discussion can't just stop here tonight. It can't just be a discussion, because ultimately, I often have said and believe that words ultimately mean nothing, discussion means nothing, debate means nothing, and the last few hours will mean nothing if we don't take action. And we need to take action. We need to take positive action, proactive action, sustainable action, persistent action. We need to make sure we take action. And lastly, to paraphrase Gandhi, our future depends on what we do today. Thank you.
Good night, everybody. Thank you.